Good morning, everybody. I have two talks. One is the non-instrumental evaluation of dysphagia, and another is rehab after head and neck surgery. So the total time is 30 minutes. This talk I will finish early so that I have 2-3 extra minutes for the next talk. Coming to the non-instrumental evaluation of dysphagia. What is dysphagia? Dysphagia means difficulty in swallowing, means you are not able to swallow or you take more time and effort to move solids or liquids from your mouth to your stomach. The purpose of assessment of dysphagia is to feed orally because it is more physiological, it is life-saving and cheap too. Why we are talking about dysphagia? Because it is very much prevalent. In any of the population above 50 years, up to 10% of people are suffering with dysphagia. When they are more than 60 years, the percentage goes to 15%. And when they are more than 80 years, up to 80% of people are suffering with dysphagia. In head and neck cancer patient, head injury patient, neurological patient or neurodegenerative patient, the prevalence ranges from 30% to up to 80%. Even in pediatric population, normal born child is also up to 5% are suffering with dysphagia. And if the child is CP or other neurodegenerative child, then the prevalence is more than 80%. We are so much concerned because these patients die with chest infection and malnutrition, and it is on us to save this patient from this morbidity or mortality. Coming to the evaluation of dysphagia, it starts from history, clinical evaluation of dysphagia. I will be talking. It starts from history, clinical evaluation, and instrumental. I will be talking to the history and clinical evaluation only. It also means bedside screening, means non-instrumental dysphagia. Evaluation is done for also the means who are bedside screening to transfer for definite the dysphagia fees or BFSS. Evaluation is done for the patient who aspiration is 90% and specific for definitive investigation like fees or BFSS. Coming to the history technique, the sensitivity to diagnose aspiration is 90% and specificity is a reliable history. You can only 65% like. Coming to the history change in eating or drinking behavior, if the patient is conscious, oriented and able to give you a history, a reliable history, you can ask some questions. Are you having some difficulty in any recent change in eating, or do you feel the behavior of food? Do you avoid certain food? Do you eat more slowly or need to change your posture while eating? Are you any saliva coming off of the mouth, any difficulty in chewing, of regurgitation, do you feel the temperature of food less intense? Starts you need to swallow multiple times before swallowing or again deglutition. Any saliva coming off of the mouth, any signs of regurgitation and respiratory system. Coming to the examination and the evaluation starts with basic clinical observations, examination, BP pulse, pallor, we have to take a wasting. The malnutrition examination and relevant systemic examination, like especially cardiac and respiratory system. Velocity, accuracy of the movement of oropharyngeal to the examination of oropharyngeal structure, whether the gag is present or resting not, observation, see for fasciculations, also wasting, assess during oral phase and timing and then ask for the voluntary movement. Also like assess for higher for the force, velocity, accuracy, elevation of the larynx, which is the movement of oropharyngeal structure, sensory testing by cotton swab, whether the gag is present or not, whether the patient is able to sense when you are touching behind the chin, also beside the chin, assess during oral phase and timing of reflexive swallow response. And also assess for high-laryngeal movement, means elevation of the larynx, which is the most important part for the pharyngeal. Coming to the preliminary examination or dry swelling means 4 fingers, ask the patient to swallow his own saliva behind the chin, for beside the chin, then second finger on the higher laryngeal elevation, upper border, and while patient is swallowing, you can see the movement or you can feel the movement, whether it is adequate or not. Increase the quantity. Coming to the preliminary examination or dry swelling, the patient ask the patient to swallow his own saliva and see for vigilance, voluntary cough, and laryngeal elevation. Then start with different. We must use liquid, semi-solid, and solid. Start from the low quantity, then increase the or on 60 degree. Protocols you can perceive protocol, or you can have your face, the spoon. We should in front of him to rule out. We must use multiple consistencies of the food. The patient
Start
should
with
be
the liquid
seated
3
in
ml,
upright
5
position
ml,
or
10
on
ml
60
in
degree,
last
and
cup
patients
drinking.
should perceive
If no
tester
aspiration signs are
face,
present,
means
then
your
start
face,
with
the
semi-solid, then
spoon
solid
in front of him
small
to
amounts, then
rule out
increase
any
gradually.
neglect or apraxia
Observe
by the patient.
for any
Start with the
loss
liquid
from mouth,
3 ml,
any
then 5
coughing,
ml,
any
10
throat
ml,
clearing,
then
the
last
voice
cup
change
if
like
no
wet
aspiration
voice, the
signs are
nasal
present,
regurgitation.
and
Start with semi-solid, then solid in
transient
laryngeal
small
elevation,
amounts, then
and
increase
please
gradually.
abort the investigation.
Observe
If the patient
for
is
any loss
coughing,
mouth, any
drooling,
coughing,
or
any
throat
voice
clearing,
change
the
occurs.
voice change like wet
Pulse
voice, the
oximetry,
nasal
the
regurgitation,
latest
oral
guidelines say that pulse oximetry
transient laryngeal
doesn't
elevation,
rule
and
out
please
aspiration.
abort the
So
investigation
it is not
if the patient is
help
coughing,
to,
drooling, or
know
any
that
voice
whether
change
patient
occurs.
is
Aspirating or not.
Pulse oximetry,
So
the
this
latest
aspiration
guidelines
is
say
screening
that pulse
tests are only
oximetry
indirect
doesn't
sign of
rule out
aspiration.
aspiration. So it is
It's-
not
it is
help
difficult
to know
screen
the whether
specifically
patient is
stroke patient
aspirating or
because
not.
up to 50%
So this
of stroke
aspiration
patients are
screening
having
tests
silent
are only
aspiration.
indirect
So no
sign
signs
of
of
aspiration.
no coughing, anything.
It is difficult to screen specifically stroke patient because up to 50% of stroke patient are having silent aspiration. So no signs of aspiration, no coughing, anything, no changes, but patient is still aspiration. So it is absolutely not reliable for severe patients. In tracheostomized patient, you can put blue dye inside the food, and after 1 minute you can suction from the stoma and see whether the blue color is coming or not. But the drawback of this test is that it is not sensitive to diagnose minor aspiration. And if aspiration is due to gastric reflux, you will not be able to diagnose it. So this bedside examination or bedside screening test, we have known that its sensitivity and specificity is not too good. So it is only a screening method, and it should not be evaluated for post-stroke patient. For other consideration after a heart attack, after respiratory problem, or even in some neurodegenerative condition, you can apply them, but not for the stroke patient. Thank you.
Snake bite. I've
Yes,
had a couple of cases been sent to me. I have to diagnose them and send them back to the physician. So your history taking, that part also has to be remembered.
Yes, ma'am. Thank you, ma'am. Now coming to the the mammoth topping, swelling rehabilitation in head neck cancer patient. To complete the thing in 15 minutes, it is 2-3 hours topic. Still, I will try to justify what I am saying. Thank you. A single day swallowing occurs 1,000 times. Oh, sorry. In a single day, we swallow at least 1,000 times, and multiple nerves are involved. A small clip.
अभी देखिए क्या है कि प्लेन लैंड कराने से पहले हमें प्लेन उड़ाने के बारे में जानना चाहिए, हाँ? और उड़ाने से पहले हमें प्लेन के बारे में अभी देखिए.
So, before knowing the rehabilitation, a short few slides about anatomy. Oral stage, oral preparatory stage, in which we grind, cut or crush the food. Muscles involved are orbicularis oris, buccinator, and muscles of mastication with their nerve supply. Tongue is the most important part. So for the preparatory phase, we came to know that 5th, 7th and 12th nerve are involved. Oral transfer proper. Food is transferred from the oral cavity to the pharynx, and the time taken is less than 1 second. Pharyngeal stage, from the oropharynx to the esophagus or so to the upper esophageal sphincter, the time should be less than 1 second. From the oropharynx, the bolus, when going to the upper esophageal sphincter, thinks that bolus should not come back to the oral cavity, should not go to the nasopharynx and should not go to the larynx. So to prevent coming from the oral cavity, the palate and tongue should be opposed properly. means the palatal muscles should be working, the tongue muscles or base of tongue muscles should be working. For the nasopharyngeal stage, the palatal muscles should be working and the posterior pharyngeal wall muscles, specifically the passment cushion, which is formed by salpingopharyngeus or superior constrictor, it should be working. Otherwise, there will be having nasal regurgitation. Muscle preventing food from entering larynx. The things should be that the larynx should be removed from the path of the bolus, means hyolaryngeal elevation, most important part of the pharyngeal phase. The larynx should, and the bolus should go directly toward the esophageal sphincter. How to remove the larynx from the bolus pathway? The hyolaryngeal elevation, of course, by the head muscles, we know the nerve supply. The anterior belly of digastric, posterior belly of digastric and genohead are the muscles which are the main suprahead muscles. Closure of the larynx should be closed at the level of true vocal cord, the false vocal cord. The aryepiglottic fold should contract and the epiglottis inversion should also occur. It is a mechanical thing after hyolaryngeal elevation which covers the larynx so that food doesn't go inside the larynx. Directing bolus towards the upper esophageal sphincter. It is done by the constrictors of the muscles. These constrictors are superior, middle and inferior constrictors. Like we constrict the जो कपड़ा हम लोग साफ करते हैं जिसे निचोड़ते हैं वैसा ये कंस्ट्रिक्टर मसल्स करते हैं to push the bolus from the oropharynx towards the upper esophageal sphincter. The inferior constrictor has two parts, the thyropharyngeus and cricopharyngeus. Second is the elevator of the larynx. The elevator of the pharynx, it shortens the distance between the vallicula and the cricopharynx, like what we catch during our cricket, the catch ball. So on constriction or shortening of the pharynx, it catches the bolus easily and take it towards the upper esophageal sphincter. The stylopalatal and salpingopharyngeus are the main muscles which shortens the pharynx. The cricopharynx opening should be there by the cricopharyngeal muscle. Cricopharyngeal muscle is both recurrent and superior laryngeal nerve. So even if when superior laryngeal nerve palsy is there, please mind the cricopharynx won't function normally. Sensory supply, normally oral cavity by the V2, V3, lingual nerve, the part of facial nerve, then the taste sensation by the, lingual nerve is part of mandibular, the taste sensation by the chorda tympani. The oropharyngeal region are supplied by the glossopharyngeal nerve, the larynx, glottis and infraglottis by recurrent laryngeal nerve. Important nerve supply for this salivary glands, the parotid by the glossopharyngeal, submandibular by the chorda and lingual by the chorda also. Esophagus, 10 seconds should be there. Esophagus extrinsic supply is the vagus, the intrinsic supply is by the vagus and splanchnic nerve from the thoracic area. So for the neurological control of swelling, we came to know that 7th, 9th, 10th, 11th, 12th nerve are involved. Sorry. Coming to the swelling therapy, what is our aim? Aim is that there should be no aspiration. The nutrition should be adequate and the hydration should be proper. Swelling therapy, two types. One is the indirect. Indirect is to strengthen the muscle, means you want to correct the defect by exercises. Second is the direct swelling therapy, when the defect can't be corrected, like you have done hemiglossectomy. Now you can't grow the tongue back. In those cases, you will need direct swelling therapy. In direct swelling therapy, you change the texture of the food, the temperature of the food, the timing means frequency amount. You can tilt your head, you can turn your head so that the bolus goes from the normal side. Different against intraoral pressure device. In the direct, the tongue which is removed, the part which is removed or the palsy is there, you can feed to the other side, you can tilt the head for the, so by the gravity, the food goes from the normal side. These are the normal tongue exercises. You can easily find them on YouTube or on different books. The tongue tip exercises, the tongue movement exercises, different protocols are there. The tongue movement against resistance, when you are trying to resist the tongue against its movement, it is strengthening exercises. Then push the tongue firmly on the side also, when you are putting the tongue from the right or left. There is another type of classic pull the tongue back while holding the tongue. Indirect is the rehabilitative devices, and direct is compensatory with food or without food. So we can have some interventional management like dilatation, botox injection, and sometimes surgery. Coming to the rehabilitation, it is for improving the lingual control of bolus. Hold a cotton swab between the tongue pull and the tongue back, and while holding the tongue, it increases sideways, upside. There are different devices. Downside, while holding the easy exercises, and India is poor country. So we can have these normal exercises without spending on these devices. Oromotor rehabilitation, it is for improving the lingual control of base of tongue. Hold a cotton swab between the tongue and hard palate, and move the tongue sideways, upside, when the bolus is downside, while holding the towards upper esophageal sphincter on the tongue. It the ballooning is better the oromotor exercises. Soft palate rehabilitation. Soft palate has two functions. One, it opposes in the base of tongue therapy when the bolus is in the oral cavity, and it opposes posterior pharyngeal wall when the bolus is going from the oropharynx towards upper esophageal sphincter. The soft palate goes and the ballooning is the best thing for soft muscle, soft palate palsy or you have weakness partly, while in the direct swelling therapy, chin tuck exercise. So by positive pressure, things doesn't go into nasopharynx. By this, you are putting the pressure on the base of tongue towards the soft palate, and the soft palate goes and opposes the posterior pharyngeal wall, so it's better. Second, in the pinching killers and all those things, the soft palate palsy or you have removed partly, while asking the patient to swallow, you ask and towards the cortex also. So by positive pressure, things doesn't touch the facial pillars. Orotactile region sensory enhancement, base of tongue and posterior pharyngeal wall. Put the spoon in a cold water and touch the tongue, the facial pillars and all those things. It increases the sensitivity on the local area, to the brain stem and towards the cortex also. Best you can touch the facial pillars before feeding. Base of tongue and posterior pharyngeal wall. The base of tongue and posterior pharyngeal wall comes together and put pressure on the bolus, so that bolus goes towards the upper esophageal sphincter. Hold the tongue and tries to swallow. Open the cricopharynx. Best in the direct exercises use gravity, means by gravity ask the patient to put sterile water and gargle on that. The base of tongue and soft palate, both movement required, and weakness is overcome. Posterior pharyngeal wall is strengthening. Second end, fix the tongue, hold the tongue and ask the patient to swallow, and ask the patient to swallow. So in the direct method, you can use gravity, means by gravity and oppose the posterior directly the base, sending the bolus towards the pharynx. But for that, the pharyngeal phase should be normal. Otherwise, on putting the tongue, aspiration can occur. Posterior pharyngeal wall is strengthening. Fix the tongue with your most important fingers and ask the patient to swallow. The laryngeal so the posterior pharyngeal wall will try to come anterior and oppose the posterior the base of tongue. This is the shaker. This is the chin tuck against resistance. On putting the tongue or holding the tongue between, and neuromuscular swallow. Laryngeal elevation, most important. We have already seen 3.5 lakh. For the laryngeal elevation, if absent laryngeal elevation is there, the shaker, chin tuck against resistance, and NMES. This is the shaker. Last few slides. This is the chin tuck. Indirect Mendelssohn maneuver is also there in laryngeal incompetence and neuromuscular. Gargling can occur, effortful swallow, supraglottic swallow. Vital steam 3.5 lakh. This is my vital steam. It costs only 12.5 thousand. Effortful swallow we can know like chewing with pressure.
Running out of time.
Other exercises, the last periphery muscle is strengthening. Indirect Mendelssohn maneuver is also there in laryngeal incompetence, unilateral incompetence exercises. You have to sometimes do tracheostomy to prevent massive aspiration. In cricopharyngeal, when direct problem is there in the muscle relaxation, you can give some war gargles or something. Otherwise, high laryngeal exercises will sometimes the postural modifications sometimes the postural modifications sometimes in gravity for and better changes in gravity of this and like better supine positioning of the oral cavity clears, like in and the supine position the oral cavity so that clears, the patient have more time and the pharyngeal cavity clears slowly so that the patient have more like time closure of left piriform sinus on head bolus. It is not going from like in closure of left piriform sinus. It is going from the one side, the normal side. It is not going from the other side. Head and neck flexion. It is going from the one side, the normal side. It is not going for valvular closure. And the last side. Please remember, head and neck flexion sometimes can be done to push the base of tongue towards for valvular closure. Pneumonia. Thank you.
Thank you, sir, for such a thoughtful discussion. I would now like to call Dr. Nilanjan Bhaumik, sir, for his talk on the whiteout.
नहीं हुआ कुछ तो निकालिए एक बार नहीं वो छोड़िए निकालिए एक बार नहीं वो छोड़िए अभी स्लाइड शो पे ही है स्लाइड शो पे ही है Very good morning. So everyone who does fees frequently is familiar with the event called a whiteout. So everyone who does physiological event fees frequently is familiar with the event called a whiteout. Tend to collapse against your scope, sending the physiological event into your scope. It happens because and giving all these soft tissues tend to collapse against your scope. It's not sending the light back into your scope. And giving a lot of other articles have considered it to be one of the limitations. It's not only Andrea Nachi's article. A lot of other articles have considered it to be. All right. For those who don't often do a fees examination, this is one of the limitations of doing a fees examination. The food bolus arrives in the oropharynx the way it has now. All these soft tissues collapse, you get obscuration of vision, and then the food bolus disappears. For those who don't often do a fees examination, to get a better perspective of what exactly is going on in this time frame, this is a video arrives in the oropharynx time frame. The way it has now, the base of tongue, all these soft tissues collapse, you get obscuration of waiting, and then the food bolus disappears. This is where the whiteout actually initiates. To get a better perspective of what exactly is going on in this time frame, this is a video of the same time frame. It's considered to be a limitation because the base of tongue, the soft palate elevates, the base of tongue is elevating, and then the bolus moves. This is where the whiteout actually initiates. If you see physiology-wise, it's likely because of the pharyngeal contraction, the base of tongue elevation, and also up to a certain extent, considered to be a limitation because laryngeal elevation actually is coinciding with the most important event, the question out here
of
is,
swallow.
can we turn this adversity into an
If you see
opportunity?
physiology-wise,
Or
it's
rather,
likely
is there
because
some
the
tangible
pharyngeal
information that we
contraction,
can
the
get
base
from
of tongue
this
elevation, and also up to a certain extent, the
So there are
laryngeal
two
elevation
measurable
occurs at the same
parameters up
time.
to the whiteout. One is the duration.
Question out
One
here
is
is,
the
can we
intensity
turn
of a
this
whiteout.
adversity into an opportunity? Or rather,
How do we
is
go
there
about
some
measuring
tangible
the
information
duration?
that we can get from this whiteout?
The whiteout duration is measured from the peak of the whiteout.
So
when
there are
there's a
two
complete
measurable
whitening of the
parameters
screen,
up
or
to
at
the
least
whiteout.
the
One
maximal
is
whitening
the
of the
duration,
screen. One is
to the
intensity
point
of a whiteout.
wherein you can start visualizing and
How do we go about measuring the
recognizing
duration?
one of the structures.
The whiteout
soft
duration is
palate,
measured from the peak of the
epiglottis,
whiteout
and
when there is a
posterior pharyngeal
complete
wall.
whitening of the screen, or at least
roughly
the
varies from
maximal
0.4
whitening of
to
the
0.8
screen
seconds and
to the
changes from
point
consistency to
wherein you can
consistency.
start visualizing and recognizing one of the structures.
To give you an
The
idea
soft
as to how
palate,
to measure a
the
whiteout
epiphyseal
pharyngeal
duration,
wall. It roughly varies from 0.8 seconds and changes from consistency to consistency. To give you an idea as to how to measure a whiteout duration, this is the maximal whiteout. From this moment on, to the point where you can start visualizing, this is of course a slowed down video, to the point where you can start recognizing the epiglottis, this uvula, this is the duration of your whiteout. Why is it important? Well, whiteout even has normal variations. For example, for thick consistencies and thin consistencies. This is a video wherein a patient is taking a liquid. Again, a slowed down video. You see it arrives, the whiteout starts, and then that's over. The same patient, when being given a semi-solid, slightly thicker consistency, you'll note the whiteout lasts a little longer. Similarly, bolus volumes also change whiteout duration. This patient, on being given 5 ml of thick liquids, watch the whiteout duration. That's a 5 ml bolus, gone, that's the whiteout duration. Again, when he's been given a 10 ml bolus. Yeah, thank you. You realize that the whiteout lasts longer? These are physiological variations. Francesco Mozzanica has done an excellent study for normal patients, considering the effects of the age, the sex, and also the volumes and the texture of the food that we eat on whiteout duration. You see out here, solids have the longest duration, large boluses of semi-solids have next, and liquids with small boluses have the shortest duration for a whiteout. Does it make a difference pathologically? Well, we'll come to that. So again, this is just Mozzanica's conclusions that whiteout duration is less for thin consistencies, it's longer for large boluses, it's higher in older people, and longer in the males. But what's more important is that shorter whiteout durations are associated with salivary pooling and swallows with aspiration. This is of course Haddad Betito's study, where he studied 75 fees retrospectively to see what effect whiteout has on the swallow. He's found that shorter whiteout durations are associated with salivary pooling, and swallows with aspiration tend to have longer mean whiteouts. This would perhaps illustrate it a little better. You see a lot of salivary pooling, you might not even be able to make out the whiteout duration. There's hardly a whiteout. Yes? Now moving on to whiteout intensity.
So Bendix Levitt did a fantastic study, and he has done an ordinal scoring of the whiteout intensity. He measures the whiteout at the peak of the whiteout when the screen is maximally white, and that is where he calculates the intensity. This might give you a better idea. There are patients in whom the maximal white is completely white. This is scored a 4. This, where there's a bit of red and then white, which effectively means that greater than 2/3 of the screen is white. This is a 3. When around 1/3 to 2/3 of the screen is white, it is a 2. This is less than 1/3 of the screen is white. And this is when there's no whiteout. This is a 0. So what impact does whiteout intensity have? First of all, let's have a quick look at two videos. One with a full whiteout, one with a no whiteout. Yeah, full whiteout, agreed? Post swallow. Watch this. Food boluses, there is absent whiteout, and you definitely see some pathologies out here. So what is the clinical impact? So whiteout intensity varies with age again, and with higher age groups, the whiteout intensity tends to lessen. It's also less for thin consistencies, rather for liquids, which is IDDSI 0 as compared to a dry swallow or as compared to a thicker consistency. Poor whiteout intensity has quite a strong correlation with aspiration. And finally, residues in the pyriform fossa, especially for thick consistencies, have a strong correlation with a poor whiteout intensity. So all of these pathologies have some correlation with the whiteout. This might illustrate it a bit better. This is a patient with a poor whiteout. We have given him a thicker consistency. Watch out here. Not only does he aspirate that, you'll realize that after a while he tends to also have residues for this. Yes. We are currently performing a study wherein we have so far prospectively seen 40 patients record their whiteout intensities. Though we have not yet come to the conclusion, but it's quite obvious that valvular residues too have some correlation with the whiteout intensity. This is for patients of neurological dysphagia exclusively. Also, in almost all patients of neurological dysphagia, in their early phases, you'll never see a whiteout of 4 intensity. It's usually the intensity is less. This is a full whiteout. Extremely slowed down, huh? Our screen is frozen. Anyway, there were no residues post this. Alternately, when you see this, this is not a very intense whiteout. There's definitely a whiteout of approximately 1 or 2. You'll realize that there are
residues in the vallicula post this. Yes. Actually, the purpose of this talk is twofold. One is to actually ruminate as to whether scoring a whiteout, both in terms of duration and intensity, have some place in our fees reporting. And second, it certainly holds the promise for research. One is finding normative data for all ages, which is still not there. Then various pathologies, whether the whiteout reduces and whether it is reduced, how much across all neuro as well as oncodysphagia cases. Then there's a lack of a standardized scoring system, especially for the whiteout intensity. What Bendix Labate has done was an ordinal scoring system which is still not been standardized. And finally, the big question, can this be a prognostic marker for patients who are undergoing therapy or any sort of treatment for swallowing rehabilitation? Thank you very much.
Thank you so much, sir, for such an engaging presentation. I would now like to call Dr. Bikram Chaudhary, sir, for his talk on post-op under aerodigestive tract. Okay. So, since sir is not available here, I would now like to call Dr. Bharti ma'am for her talk on conservation laryngeal surgery.
This is pointer. Yeah. Good morning, everyone. At the outset, I thank Dr. Vikas and his team for giving me this opportunity. The organ preservation protocols, we all know, it's surgical and non-surgical. I'll be dealing with the surgical. They are open and endoscopic. These are the various surgeries which are there. And the goal of any organ preservation surgery is to preserve function without compromising the cure rate. The function of the larynx must be maintained without the need for tracheotomy or the feeding tube. And we all know cricoretinoid unit is a preservation of one cricoretinoid unit with the associated cricoid ring, allows for speech and swallowing without a permanent tracheotomy. And what are the factors to be considered? We have the tumor factors, staging, status of the neck, if it is extranodal spread is there, or N2, N3, location of the tumor, and then exophytic or the endophytic. And the patient factor importance is the distance travel to hospital, previous radiotherapy, and then access and exposure and the pulmonary comorbidity, and the importance of voice and professionals. Institutional experience of the surgeon and the cost. Oncological assessment, that we need to know the functionality of the larynx. In the glottic sphere, the impaired vocal cord mobility may be either because of the thyroid muscle involvement, either partial or the extensive muscle involvement. Supraglottic, the fixation or the actual fixation occurs whenever there is cricoretinoid joint involvement is there, or the intrinsic muscle involvement. Then also we need to look for the extension outside the larynx, whether thyroid cartilage irregularity is there, or you have any bulge in the over the cricothyroid membrane or the thyroid membrane. These are the various surgeries which we have in glottic cancers, vertical hemilaryngectomy, and all the variants depending on the extent of the tumor. And then this is the European classification 2007 modified later, and these are the various types of cordectomy. And this is the indication for various stages, T1S, T1A, T1B, what cordectomies, type of cordectomies we do. Supraglottic horizontal laryngectomy, and then the extension, depending on the extension of the tumor. Now, how the literature supports us. We have the open partial laryngeal. Let's just brief look into the history. Theodore Billroth was the first one to perform in 1878 the open hemilaryngectomy. It's a surgeon who used to treat these patients rather than referring for radiotherapy. Then we have the transoral laser surgery for laryngeal carcinoma. This is a landmark study by Striner, who said that who had 240 cases, and there was only 6 local recurrences, with 1 patient needing total laryngectomy, but adjusted 5-year survival is 100%. This was from 1979 to 1985. Then what are the principles? A small lesion can be excised in toto, or if it is a big lesion, you transgress the tumor, go to the lateral aspect of the vocal cord, and then you get the margin. Then these are the advantages of the transoral laser surgeries. Complications, usually granuloma, laryngeal edema, but in mice had anterior web also. And then this is a systematic review of laser versus radiotherapy. No statistically significant differences were found between them regarding the local control. And this is also in early one. This is TLM versus as a primary treatment for selected T3 and supraglottic cancers. This is salvage laryngeal surgery. This is TLM versus open. Both had the same, disease control. Quality of life, which is very important, and functional outcomes. This is a systematic review. The evidence base to date demonstrates comparable vocal and quality of life outcome for radiotherapy and transoral for early glottic carcinoma. There's but a need for consensus on which measure of vocal cavity and life satisfaction to be used in research trials to allow comparison between the studies. Now, coming to the coblation for cordectomy, this is a small study, only 6 patients over a period of 1 year. They said it's good results. And this is 40 patients, but only thing is, it's included both the glottic as well as the oral cavity and the oropharyngeal malignancy. But the main problem here was the probe. The size of the probe, which obscures the view of the good margins you get. Coming to the partial laryngectomy, the amount of excision we do. First we mark the landlines and then we open. Then opposite side, 5 mm of the perichondrium we elevate. On the same side, this is a radiorecurrent cancer. Same side, we elevate the perichondrium up to the posterior margin. And then we come to the midline. This is the posterior border of the thyroid cartilage. Come to the midline. And then you open, enter in the subglottic mucosa. This was a lesion. And then we completely resect the lesion. And only thing is, when you're doing it posteriorly, you should be careful not to damage the postcricoid mucosa. After resection, we don't do any reconstruction of the neoglottis. We just suture the perichondrium to the opposite perichondrium, and then the strap muscles we suture. Airtight suturing should be there. This is an excised specimen. This is one where we had a small granuloma at the anterior end. This is another patient. Supraglottic horizontal laryngectomy, these are the prerequisites when we go for the surgery. As usual, landmarks, and then we make an incision. Here, the perichondrium is elevated on both the sides from the superior margin of the thyroid cartilage up to the midpoint, anterior curvature. You elevate the perichondrium. Then at the level of the false cord, we make the transection. Before transgressing the thyroid cartilage, we drill to make a hole so that it helps in suturing. And also mid part of the aortic bone, we cut. Here is the drill holes. Sorry. And then we open. Once we excise, this is how it looks like. And then we suture the thyroid cartilage to the base tongue superiorly. First we put sutures and then we tie the knots. so that airtight seal will be there. So this is the, I think, third post-op day. Voice. Oh, बरोबर आहे. Okay, छोड़ा. And then next I'll be showing about the, it's come. No. Now the coblation assisted, then we moved on to the coblation, and then we started doing with the coblator. It's a good tool. We all know the lateral damage is less. It's because the the heat is up to 50 to 70 degrees, whereas with other instruments it's more than 40 degrees centigrade. And then like the regular principles we apply, infiltrate, we elevate. And when we started doing this, we gave first the tissues to our pathologists so that they should get used to the type of cells they get when we burn with coblation. Whether anything different is there, we made them. They said nothing different, so that they can give the report properly, whether we have got the positive or the negative margins. Only thing is with the coblator, the tip is it's a MLW. The tip is little big so that the obscures the view. Then the laser surgery, now we started with blue lasers. We all know the blue laser, both are type 3 transmuscular. The blue laser it has a wavelength of 450, and the main thing is it's photoangiolytic, that it's absorbed by the hemoglobin, so that lateral spread of energy is not there, and good tissue dissection, and it's a fiber operated, as well as contact or non-contact also you can use with this. Only thing is it doesn't have a filter, so that you need to protect your eyes. Still type 1 cordectomy I have not done with this because I don't want to rush to it till we get used to it with type 3. We keep one suction tube also. And this, sorry. Type 5.
So let's get all these ENT manage.
Yes. Thank you, ma'am.
Thank you very much for sharing your values with us. I would now like to invite our esteemed chairpersons, Dr. Anil Gaurav Bhatni sir to share the upcoming segment delivered by Dr. Bharat Panuganti sir on laser benign laryngeal pathology.
When we offer a surgery to a patient, whether it's a standard, we always have to be explicitly considerate of the main thing, the endolet. The Faringa score isn't exactly applicable. If you think about head and neck anatomy, how big is the tongue, teeth, narrow mandible, distant techniques that we're using to get a open view of the larynx what we've been doing innovation, system that with my glottoscope system. We talked before, but there is an advantage up against the endoscope. That happened. In any case, this is doing something interesting. Put it there. I think it's important for a couple reasons. One, why what I'm doing is wrong. way is to put it out into the this is a case where theory more global exposure, potentially assisting with a large section. I figured
immediate tests that cause high risk of apnea and
like a time-sensitive intubation and careful anesthetic monitoring in kids is very important. There are a lot of challenges will be there. Post in a unknowingly just between the autos, his neck is. So this is a endofuture surface
going ahead to put in the absorbable plates there on the trachea to support the trachea, let the trachea grow around that, and then maybe he will come out of the tracheomalacia. So these things are happening, and this is the place for interaction to know which place is doing such a wonderful job, and it should be give and take for all. And about the laryngeal surface of epiglottis, Bharat was mentioning, this is commonly seen in all the laryngeal papillomas. If you see the laryngeal papillomas, especially pediatric and few adults, the most of the bulk comes from the laryngeal surface of the epiglottis. And it's very difficult to see through the laryngeal surface. So the robotic 30 degrees endoscope and the instruments you can manipulate, that is really a good challenge. Till then, till you have a robot, what I would do is take a 30 degrees sinus endoscope and take the malleable forceps. They are available outside. I mean, I am using Santosh Surgical. I don't have any commercial relation, but he has got malleable forceps, malleable punch forceps. So 30 degrees laryngos, sinus endoscope and malleable forceps. Thank you.
Thank you, LVA and Dr. Vikas and the organizing team for giving me this opportunity to talk on laryngotracheal trauma. Laryngotracheal trauma grows grossly underreported, and because it's unrecognized, goes many a time unrecognized in India. If not dealt appropriately, the patient could have airway stenosis, a hoarseness of voice, and swallowing problems. So it's important that we remember when a patient comes with acute external laryngotracheal trauma, our focus should be directed towards securing the airway. Only then we direct our attention to the phonatory function and the swallowing. So for a successful outcome, it's important that we recognize the injury early. We evaluate the patient accurately and determine what exactly is the problem and initiate appropriate treatment. If surgical treatment is required, it's best that we treat the patient within 48 hours because any delay in the treatment would have a poor outcome. We are all familiar with the Schaeffer-Furman classification. This is a guideline for us to help us choose what is appropriate for the patient. With group 1 trauma, these patients have minimal airway symptoms. They may have a small hematoma, a small laceration, and no detectable fractures. These patients can be managed conservatively. We had a 48-year-old man who came with a two-wheeler collision. He had hoarseness of voice and difficulty in speaking. On examination, the patient didn't have stridor. An X-ray in the ER showed that there was no gross airway leak into the soft tissue. The framework appeared to be normal. The flexible laryngoscopy of this patient shows this hematoma in the aryepiglottic fold and in the immediate subglottis. We did a CT scan and that showed there was there was a swelling in the aryepiglottic fold, the pyriform sinus, and the subglottis. We decided to treat this patient conservatively. He was given antibiotics, he was given steroids to reduce the edema, and he was discharged in 72 hours. When it comes to group 2, the patients have a little more breathing difficulty. The edema could be a little more or the hematoma could be bigger. And again here, there is no cartilage exposure and there's no displaced fractures. Here we could either treat them conservatively and we need to keep a watch to see whether they need a surgical intervention. This was a picture of a patient with group 2 Schaeffer-Furman trauma, and we treated him conservative. And this was a picture of the patient after 48 hours of conservative management. Notice that the hematoma is reduced, the airway is fairly adequate. Coming to group 3, here the edema is more, the patients
Then-
have a lot of, there could be trauma in the sense that cartilage could
We
be
dealt with
exposed. The vocal
segmental
fold
tracheal
would be-
restriction and
there could
reanatomy.
be immobility. Here the important is there is trauma in the sense that these patients definitely should have an open surgical approach. Now many a time we have patients coming to the ER with a trauma. Now how do we secure the airway? Is it safe for us to go with a endotracheal intubation or should we choose a tracheostomy? Schaeffer prefers tracheostomy because they say if we are not able to see the trachea and the immediate subglottis, it's likely that we may cause more trauma. This young software engineer sustained this injury as he was traveling in a bus, hit the rod in front of him, and sustained the supraglottic injury. You can see as it goes lower, what was exposed is part of the arytenoid cartilage. We did an emergency tracheostomy in the ER and proceeded to repair the trauma. A similar patient who had group 3, this was a blunt trauma. The patient came to us after 24 hours after the surgery. And when we did a scan, we found he had progressive edema, subcutaneous emphysema, and there was air leaking all around the trachea into the chest. So we took him to the operating room, and this is our anesthetist doing a scopy for us. The plan was if they could see the trachea straight away, the cords and the trachea straight away, they would proceed to intubate the patient so that we could proceed with the repair. I don't know, it's not playing, sorry. They were able to pass in a tube and we proceeded to explore the neck. After the intubation, we did a tracheostomy, and this was the injury that we saw. Here we have the cricoid fracture here, and there was a tear of the cricotracheal membrane. We repaired this patient too. Now when it comes to grade 4, here they have more than 2 fracture lines and it is displaced. This group of patients requires stent placement. This was a patient, again, a blunt injury trauma, but the neck wound, he came with a neck wound that was sutured. He had difficulty in swallowing and breathing, and there was subcutaneous emphysema. The laryngeal framework was disrupted. When we did the endoscopy, we found that we could see arytenoid cartilage exposed. The vocal cord, one was mobile, the other was restricted. The scan shows the fracture. There are multiple fractures and they are displaced. And the image below also shows the similar displaced fracture. This was a picture when we exposed the larynx. You can see the thyroid cartilage in multiple pieces. What we did was we reduced these fractured segments and sutured them together, and we had to place a stent. We used an endotracheal stent for this patient, a modified one, and this was the picture on follow-up. 6 months later, we see that the larynx is mucosalized. The middle picture shows the shortened vocal cord, and this was because part of it was, though we tried to repair it, it was not perfect. The cords, they were mobile, but the left one was slightly restricted. The subglottic airway was normal. We were able to decannulate the patient. I'm presenting this group 4 patient again, another group 1, because this particular patient came in shock because the patient had an acute abdomen. The liver was lacerated. Patient was taken to the surgical ICU. And there, 24 hours later, the ICU doctors noticed that there was subcutaneous emphysema and the patient had falling saturation. So they called us, and on the second resurvey only, we were able to pick up this trauma. What we see is the fractured cricoid arch when we examine the patient under anesthesia. Prior to that, we had done an imaging, and that's how we said the patient has a laryngeal trauma and took him to theater. This patient also needed a stent. Now, briefly about group 4, there is a cricotracheal separation. In India, we see this because of bull-gore injury. This particular patient had fracture of the anterior arch as well as the lamina, the second image with a bigger arrow. After we repaired it, we put in a hood stent. We retained it for 2 weeks. And when we removed the hood stent, the picture on the left, the first one, shows the subglottic region. There is a raw cartilage. Cricoid arch is raw. The vocal cord was edematous. A month later, we see that the cricoid area is mucosalized, and 3 months on our follow-up, we saw that the vocal cords were normal. So, the goals in laryngotracheal trauma, we have to repair the mucosal lacerations. If there is an avulsed epiglottis or an anterior commissure, we have to resuspend it. If there are dislocated arytenoids, it has to be repositioned, and all fractures should be reduced and fixed, and no cartilage should be exposed. Is there a role for endolaryngeal repair? Minor lacerations can be repaired, hematomas can be drained, and cricoarytenoid joint can be dislocated. This is Dr. Paul doing endolaryngeal suturing for a vocal cord that is avulsed from the arytenoid. When do we have to do an open laryngeal procedure? Any unstable comminuted fracture, definitely in cricotracheal separation, when there is a detachment of the anterior commissure or the avulsed epiglottis, and when there's extensive mucosal disruption. Stenting can be done with whatever is available. If we have no stents, use the glove and pack it and suture it close, and it can be filled into the lumen. We have hood stent in our institution, and if we run out of them, we use, and many a time we use endotracheal tubes because they are cheap. We do use T-tubes, but not as frequent as the endotracheal tube or the hood stent. For the swallowing, initially after the surgical repair, patients have a problem swallowing, so they are on NG tube feeds. If there's an associated esophageal injury, we have asked our surgeons to perform a feeding jejunostomy. Follow-up of all these patients are important. The 2 weeks after we discharge them, 3 months, 6 months, and for a year, till we know the mucosa is healthy and stabilized. Because various forms of complications are seen. We have patients who've had commissure webs, false cord granulations, interarytenoid adhesions, suprastomal granulations, and sometimes laryngotracheal stenosis, which can be ballooned and airway improved upon. So I'd like to conclude saying it's important that we assess the airway well, establish a safe airway before we proceed to repair the injury. If you have an experienced anesthetist with us, either in the OR or at ER, they can intubate, provided they can see the underlying subglottis and the trachea. Otherwise, we should not hesitate to do a tracheostomy under local anesthesia. It can be in the ER or in the OR. And important, avoid blind endotracheal intubation. Go ahead with an emergency tracheostomy. When we do an emergency tracheostomy, it should be a little lower than the usual, because sometimes the patient may have a cricotracheal separation and we may lose the airway, or the patient may suddenly collapse. We had one such experience during the COVID time. It's important. Why do we say that? It is to avoid injury to the area of the laryngotracheal trauma. And many a time, patients come intubated through the wound, and if there's a traumatic tracheotomy, use that first before we have a controlled situation. And as I said, regular follow-up is important. Laryngotracheal trauma is challenging, but it is certainly rewarding, because at the end of it, we have a very beautiful picture. with the patient being decannulated, and most important is we intervene at the earliest. I have a great team back at home who helps us get good, for the good outcome. I'm thankful to all of them. Thank you one and all for a patient hearing. If there are any questions, I'm happy to take.
Hello. Just a quick question, ma'am. Very nice presentation. In grade 1, the steroids which you give is locally injected or it's oral?
No, it's oral or IV.
Okay. Can
Usually
you
we
nebulize
give them
with
IV.
steroids?
Oh, we can,
Well, that will be a direct impact on the...
correct.
And the second question is that the fixation you do said OPAL, reduction in fixation, that is you done with mini plates?
No,
or
all our
sutures?
patients, we use Vicryl.
Vicryl only.
Yeah.
Yeah. Thank you.
Thank you very much for excellent presentation. We used to work in Gujarat, and during Makar Sankranti, that is Uttarayan, there were lots of cases that cut throat due to that dhaga or manja of
Close
kite.
wire injury. Yeah.
So we used to get many cases and we used to repair that.
Yeah.
Nowadays they have got that innovation of having a wired string on the bike from handle to the carrier,
Yeah.
especially during the Uttarayan. So that saves many of the patients from cut throat injury.
Okay.
That thread slides over that antenna sort of wire they are having on the bike
Okay.
from handle to the carrier.
Okay.
So it makes a loop.
Oh,
So if a thread comes, it passes or slides over that loop.
oh, that's
And
interesting.
it saves the driver and the family.
Oh, that's good.
So that's a good innovation. Thank you.
Thank you.
Thank you very much, ma'am, for such a comprehensive presentation. I would now like to call Dr. Harishankar Jayarajan for his talk on multidisciplinary approach and management of complex airway diseases.
Thanks for that, guys. That was an amazing presentation, Dr. Matthew. That was very impressive. It's also, Dr. Panagati and I were talking, it's very interesting the differences in the patient populations that we see. We were just talking, I think I can count on one hand the amount of Schaefer 4s that I've seen. Actually it's interesting that you had the bull gore. That's the one I saw. I had 2 bull gores, and only because I live in the South. In North America, there's no bull riding. That's all, and you probably wouldn't have seen it up north at all. But no, it's very interesting. So I'm going to talk today about, is it on the screen? About how I approach airways at UAB, which is a multidisciplinary approach, particularly to complex airway problems. When I started at UAB in 2019, as you know, Dr. Paul Castellanos had left UAB, so there was no one managing upper airway disease at UAB when I got there. And at the time, there was a surprising amount of what we found was predominantly iatrogenic airway injuries, which forms the bulk of my airway practice. In an effort to try and standardize the care of these patients across the institution, a lot of these patients are relatively medically infirm and have relatively complex surgical issues. I formed this, what we call a complex multidisciplinary airway team. And it consists of interventional pulmonologists here, my thoracic surgeon, Jim Donahue, interventional gastroenterologist, and this is the ENT team. Like I said, I still keep Bharat Panagantian on my slides. But all of us together form the complex multidisciplinary airway team. We met once a month and collaborated on the more complicated cases to basically provide a uniform care across the hospital to all these patients. And like I said, most of our cases are inflammatory in nature, usually iatrogenic, either through intubation-related injuries or tracheostomy-related injuries. We do see a few tumors and occasional traumas. One of the other issues we had was, especially during COVID, we were finding that there was a significant number of iatrogenic injuries due both to prolonged intubation, inappropriate use of tracheostomy tubes, but also inappropriate care of tracheostomies, and that was forming the bulk of my airway lists. And so we led a multi-year quality care initiative to standardize airway care across the hospital, with the goals mainly being to standardize care, standardize equipment, and really sort of work on education of both the patients and the staff on how to care and look after tracheostomy wounds. Because you can see here, this was quite the standard that I found when I went to UAB. Horrible tracheostomy wounds, and endotracheal granulation tissue. We saw a lot of patients with posterior glottic stenosis due to prolonged intubation and inappropriately sized endotracheal tubes. And inappropriate use of tracheostomies resulting in tracheoesophageal fistulas and significantly stenotic airways. As part of this initiative, we also created a tracheostomy care team. Now that care team lies under the umbrella of the complex airway team and the inpatient ENT consult team. It consisted of 2 advanced physician assistants and a respiratory therapist that would round on these patients every day. So there was a significant number of patients that they would review each day. And like I said before, they would educate the staff on appropriate tracheostomy care, educate the patients that were leaving the hospital on appropriate care and appropriate use of humidification and suction. And they would ensure that every patient followed a standardized decannulation protocol, which led to a significant reduction in airway-related morbidity. We found a 60% reduction in trach-related admissions. And in my hands, we're still working through the numbers. We found it very difficult to sort of figure out exactly what the numbers were because there was no standardized recording of these patients before I got there. But what I noticed is a significant reduction in the number of patients I took to the operating room to intervene. At the moment now, I would say I treat a couple of these patients a month. I was treating about 4 or 5 every week before we formed this team. And this is the team here. But despite our best efforts at preventing these injuries, we still find that we have a lot of patient-related, a lot of patients with iatrogenic injuries, either from outside hospitals or even from our own institution. This is a young girl who was unfortunately paralyzed from a motor vehicle accident and developed a near-complete suprastomal stenosis. Given the length and the compound nature of it with significant cartilaginous collapse, we decided to take her to the operating room for an open trachea resection. At UAB, this is how I perform my open trachea resections. I perform it as a joint procedure between myself and the thoracic surgeons. I don't do a lot of the perilaryngeal releases, mainly because I wasn't happy with the level of dysphagia that we were using. I would, if I did, I would do a suprahyoid release, but I still didn't like the degree of dysphagia, and I didn't feel that the amount of relaxation that I was getting was enough for some of the more complicated cases. And what I found is that Dr. Donahue, my thoracic surgeon, could perform a mediastinascopic release both of the entire trachea and the upper bronchi through the cervical incision that I created. And so this is the technique that we eventually started using. He would come in, perform a mediastinascopic release after I expose the stenosis. It takes him about 25 minutes to do. It's incredibly safe. There's no bleeding because he's got direct control over the trachea and the mediastinal vasculature. And like I said, it takes about 25 minutes to do, and it allows us to do pretty extensive resections. I think the longest one we've done to date is about 7 centimeters with a tension-free repair. And there's no thoracotomy. It's all done through the transcervical incision and adds. Otherwise, like I said, we perform a standard open trachea resection the way that most of you have described, as Dr. Mathers, you described earlier today in the other room. We do a subperichondrial dissection. And most of the time, because it's a stenotic disease, we do a complete 360 resection and reanastomosis. The patient, we extubate the patient in the operating room. I use a Grillo stitch, but it's only for one night. It's really just as they're emerging from the anesthesia. And so I'll do a Grillo stitch and then take the stitch out the next day. We keep them in hospital for 5 days. And then I bring them back in about 5 weeks, really to debride any granulation tissue that may be present there. In the second time, I'll just crack on. And this is kind of the result that we get. So this is her pre-op, and this is her post-op. I find that the vast majority, I use vicral sutures, so by the time I get here, all my knots are extraluminal. So I find that there's very rarely much granulation. Occasionally I will find some. The most I've ever had to take someone back is twice after a trachea resection. Sometimes, like this girl, I don't have anything to treat afterwards. So who do I offer open trachea resections to? Primarily those with superstructure collapse, A-frame stenoses, recalcitrant mucosal disease, and long segment disease get a resection, and obviously tumors get a resection. That being said, I do feel that there are certain contraindications in my hands, people that I would refer to, prefer to just trach. Classically, this is limited to chronic aspirators, patients with poorly controlled diabetes, obese, so generally morbidly obese patients with a BMI over 40, I probably will refer to tracheostomize until they can lose their weight. And obviously, if they have a chronic need for ventilation, I'll leave them with the trach. These relative contraindications are not so much a roadblock to me. If someone's got a bilateral core paralysis, I tend to try and figure out other options for them. I have done tracheoresections in these patients, but we just have to be a lot more cautious with how they recover. And radiation, I've done it on radiated patients, but I'm obviously a little bit more cautious. And often I'll rotate a local flap over the suture line to ensure they have good vascularity. But we are often faced with patients that you can't resect and you can't trach. So the question comes down to how do we manage these patients? The classic examples of either patients that are unfit for resection. This is an example of a 38-year-old female who, despite her age, given her lifestyle choices, she had significant medical comorbidities. She had a long segment stenosis. She also had a short neck, so most of the stenosis was actually extended into the chest. And so this is something that I did in concert with my interventional pulmonologist, Dr. Joseph George. I would go in and do a standard endoscopic tracheoplasty. I would do a laser division of the mucosal disease using a CO2 fiber laser, and we do this classic Mercedes-Benz type incision. Let's see if I can move this along. Once I've done that, I'll inject 2 mils of dipamedrol into the mucosal bridges. Oh no, that's not what I wanted to do. And then I'll dilate with a balloon. And then once I've dilated, I use the Aeros non-compliant balloons. Once I've dilated, I'll then place a memetazine-eluting biodegradable stent. It's a sinus stent that they use for frontal sinus stenosis, but I find it quite useful in the airways as well. So I'll place that across the denuded area, and then Dr. George will then come in and place a covered nitinol self-expanding stent. We'll barrel it through there and then use that to hold the stent in place. And then I'll send the patient home. So this is an outpatient procedure. They go home on oral antibiotics. They get an intraoperative dose of steroids, but they don't go home on steroids. And then I bring them back in about 3 to 4 weeks. This is kind of how it looks. You get an area of mucostasis and some mild inflammation, and then I remove the stent. After I remove the stent, I inject some steroids and dilate, but that's usually all I have to do. So then I discharge them home. I usually bring them back in about 2 to 4 weeks. But you'll see, this is sometimes the most annoying part, is trying to grab the stent, but it always comes out. I tend to use covered stents, even though I leave them in for a short period of time. I don't use the bare metal stents, mainly because I'm afraid of how much mucosal integration you'll get in the stents, and you'll see why when I show you a case that I saw from someone else. But you can see that it's already started to mucosalize, and there's significant improvement in the luminal diameter. And in general, that's relatively stable. In fact, one of my partners, this was done about 4 years ago, one of my partners still sees that lady for other issues, and the airway stays patent. I also do it, this is another girl I did it for. She was a 21-year-old female who was involved in domestic trauma, sustained ballistic injury, prolonged intubation, and her stenosis was completely intrathoracic. So to get to it surgically, she would need a thoracotomy. And so I performed a similar kind of procedure on her because the thoracic surgeon and I felt that if we could address it this way, she could avoid a major procedure. And for the sake of time, I'll just move on, but it looks exactly the same as the other one. And this is what it looks like the 3-week review where after we pull the stent out. You can see, not as well mucosalized as the other, but certainly a lot more patent. I think I gave some oral steroids just because of the hypergranular inflammatory nature of the picture. I gave her some steroids for a little longer. Is stenting perfect? No, it's not. You can see the first video on the left is one of my early ones that I did. It migrated, the stent migrated, and I think this is often something that happens because When the stenosis is too proximal, too close to the glottis, it tends to migrate a lot more. It wasn't a big deal. The picture looks pretty inflamed now, but this gentleman actually did fine. I gave him 2 weeks of steroids, and when I brought him back to the operating room, a lot of the glottic and infraglottic edema and swelling had just completely resolved. But it has changed my practice. I generally don't do this for stenoses that are particularly high. And this is the case that made me wary against bare metal stents. This is a patient that came to me with this stent. It had been placed about 5 years before by another surgeon. It was a bare metal stent that is now chronically colonized. She's 79 years old and medically infirm, not very fit. And the problem now, you can see that there's complete mucosal integration of the posterior wall through the stent. And so to try and pull the stent out, she'd need an open procedure because it's very likely it will tear through the trachealis, and that's in the mediastinum. So what we do now for her, she just comes in periodically, about 4 to 6 monthly, for me to do a flexible bronchoscopy, laser divide any adhesions, and then just clean out the stent. So that's why I'm very wary about stents, particularly stents that are placed long term, and that's what made me wary about bare metal stents. As soon as I saw that patient, I was like, oh, I'll just use covered stents. So yeah, my approach to stents, in general, I feel that it works well for distal stenoses and long segment mucosal stenoses. I think that works well. I will use it occasionally for patients that present with a hemi-A-frame, like what you can see here. In general, I don't like doing endoscopic tracheoplasties for full A-frames. I will very rarely do it. I just find, in my experience, when I've tried to do that, it just leads to complete collapse long term. But for hemi-A-frames and people that are medically infirm and not fit for an open tracheosection, this works okay. I'll basically denude back the cartilage and then put a stent in to let it mucosalize over there, relying on the contralateral cartilaginous framework to keep it stable. And finally, this is a case of tracheomalacia. These patients often don't come to me. They often come to the interventional pulmonologist. But since we formed a multidisciplinary team, we all work together to help these patients. If this is an EDAC type tracheomalacia, to be specific, if the EDAC is worse in the distal trachea and upper bronchi, they go to my thoracic colleague, where they'll do a VATS procedure and then basically suture plicate the posterior trachealis to a proline mesh. And that works really, really well. But if the tracheomalacia is more proximal, they don't really get involved. And so what I do for these patients is I'll basically take a Montgomery T-tube, cut off the T end, and slide it in as a long-term stent, and then I'll secure it with a transtracheal suture, transcervical suture. And then I basically send them to a program where they lose weight through exercise and bariatric consults. Often these patients can't exercise because their malacia prevents them, so the stent allows them to do that. And so it's part of a multidisciplinary approach to help these patients. My mentor, Guri Sandy, used to say these patients, the only way they get really better is if they get to lose weight. It doesn't work all the time, but a lot of them do get better with weight loss. So I put the stent in so they can engage in a weight loss program. Every 6 months, I'll bring them back to sort of debride the stent. This lady basically needed 3 stents, so after 18 months, she lost enough weight, the EDAC had resolved, and she now is fine. And that's all. Thank you very much, guys.
Thank you very much, sir, for such a wonderful presentation. And for the next topic, I would like to call upon Dr. Sachin Gandhi, sir, for his talk on immobile vocal folds, palsy versus fixation.
Thank you very much. I think people will start having respiratory difficulty after hearing so many of difficult cases and all obstructions. Now this title is very important. Surgical options in management of bilateral immobile vocal cords. So it's not bilateral abductor palsy. We term these patients when we see bilateral median vocal cords. What we say clinical condition is bilateral immobile vocal folds. So all forms of reduced or absent movements of the vocal fold, which can be of neurological origin, that is what we say bilateral abductor palsy, or it could be total or partial fixation of vocal cords in adduction. So it could be either fixation or it could be neurologically origin. Now clinically you have to know whether they are immobile because of fixity or they are of neurological origin, because the treatment options absolutely one against the other. I mean, they are at the extreme ends. We'll see this with some clips. So there are multiple factors which would result in fixation of the cricoarytenoid joint. There are external trauma, intubation trauma, accidental trauma. Radiation is now one of the most common cause we see. All these patients of functional preservation and chemoradiation for oropharyngeal laryngeal cancers, they would come with respiratory distress, and what we see is the cords are immobile. That is because of cricoarytenoid joint inflammation, maybe fixation after that. So these are various factors. Now I just have to mention here, when a patient with post radiation bilateral immobile vocal cord comes into the clinic, don't think of surgical intervention, a chordectomy or any other thing, because radiation has already given good inflammation to the not only vocal cords or cricoarytenoid joints, but the whole entire airway. As soon as you start manipulating with the airway, when the patient is, anesthetists are trying to take out of the anesthesia, he is going to have post-operative edema and you are going to land in trouble. So maximum, if they come within 3 to 6 months of radiation, then maybe balloon dilatation or straight away tracheostomy. And if when the fibrosis is quite matured, so maybe 6 months, 12 months, 2 years after the radiation, then you can think of definitive surgical options. In children, pediatric age group, bilateral immobile vocal cords are usually of central origin. So you have to have a neurological reference and all the imaging done to rule out the central causes. Okay, so when it's of inflammatory in origin, what you see is they would not land up in respiratory distress on one go. First episode of bilateral vocal cord palsy, there is usually dysphonia because both the vocal cords are going to be in a cadaveric position, and on follow-up you will see they are coming in the midline and producing respiratory distress. There are various other conditions. Young females staying in hot hostel, they can come in the midnight to your ER with a lot of stridor in the sense noisy breathing. But when you put the oxygen, this one, you will find the saturation is around 90, 95, 98. So saturation is quite good, but patients have distress. And when you put in the scope, you will see vocal cords like in a median position like a bilateral abductor palsy. So these are conditions which mimic bilateral vocal cord palsy and have to be diagnosed with oxygen saturation, and then nebulization and all other things, you have to manage them. Maybe they would require Botox, and if not, maybe one of the case you can do chordectomy. But these cases have to be identified, and these are not uncommon to see with youngsters going out for the education purpose. So what are the investigations? The best of the investigation would be the endoscopic examination, which would show you the vocal cords in the midline. You have to do imaging to rule out any etiology along the course of recurrent laryngeal nerve. If it is a central origin, maybe you can do MRI of the brain. but mainly you have to do the neck and upper chest to rule out any lymph node or some mass on the course of the recurrent laryngeal nerve. Laryngeal EMG, of course, you have to do, you have learned in other presentations to know about the status of the vocal cord palsy. Now, whether it is a fixed cord or a paralyzed cord, what are the things clinically available to you? So, first is a stroboscopy. If the cord is fixed, then there is a fibrosis and you will not be able to see the mucosal waves. So, that's the maybe application of a stroboscopy. Not clearly visible here, but if it is a bilateral abductor palsy, see the vocal cords are in the adducted position, but the mucosal waves are quite normal. See, you see the mucosal waves with a good amplitude. So this is a neurological bilateral abductor palsy. Now, when the patients with bilateral abductor palsy come to your clinic, you have to rule out other causes of aspiration as well, like teophistulas or concurrent lesions in the lower respiratory tract. So you have to do a complete endoscopy. So pass up to the maybe carina with your flexible bronchoscope or laryngoscope. Now the aims of treatment is to get adequate airway, good voice quality, because patient is going to ask about the phonation whatever you do to the airway, and of course the aspiration you have to prevent, so give good competence to the for complete swallowing, preventing any aspiration. So these are various options available. Tracheostomy, no longer we are going to do tracheostomy in the patients unless they are old and unfit for any surgery. Then they would line or a palliative care patient, they will go in tracheostomy. All cases would go for transoral approach. Okay, we'll just go and see on the clips. Now this is the case we have seen yesterday, maybe a classical partial chordectomy or posterior chordectomy with partial arytenoidectomy is a classical treatment for bilateral abductor palsy of neurological origin. Okay, now in which you resect part of the posterior posterior part of the vocal cord, that is the posterior cord which has a vocal process. So you have to resect the vocal process and part of the medial arytenoid. Okay, so I will show you the clips just to understand. So this is a acute blade. I am taking the incision at the anterior end of the vocal process. Audio. Audio. There is a commentary actually. So you have to go up to the lateral extent of the vocal cord origin. So for that you have to remove part of the false vocal cord. So this is the false vocal cord, it's a true vocal cord. So an horizontal incision.
Vaporize the tissue in the incision line.
This is Mr. Oswald.
Until the vocal fold is severed.
What is now this is choroidotomy. Choroidotomy means take the incision on the vocal cord.
Continue vaporization lateral to the arytenoid.
This is on the false vocal cord.
Vaporize the mucosa on the surface of the arytenoid.
This is high frequency jet ventilation in the posterior cortex, ventilating the patient, which is laser safe.
Note the anesthetic tube protecting the posterior commissure.
This is very important in case of bilateral abductor palsy. You have to always protect the interarytenoid mucosa.
Continue vaporization in the deeper planes.
So this is a part of the arytenoid, and when you see this glow, that means you are on the
Exposure
arytenoid.
of the arytenoid is seen here as whitish tissue which produces a flash with each strike of the laser beam.
Why flash? I've told yesterday, because cartilage doesn't have water content, so the light is going to get reflected, the laser light, no absorption.
Stretch the arytenoid medially to vaporize surrounding soft tissue and remove the excised arytenoid.
Now, when you see this, you can't see the true vocal cord absolutely on the operated side. What has happened? Is the cordectomy means you have vaporized everything. Actually, I have taken incision on the posterior 1/3 of the cord. The anterior 2/3 is still there. Why it is not seen? Because the elastic forces are there, and you are cutting through the elastic forces. So there, the vocal cord loses the anchorage to the arytenoid, and it is retracted above. What I want to tell you is even a chordotomy, that is the horizontal incision, would also give some airway, because the cord would be moved anteriorly and this posteriorly. Okay, but if you have to have a adequate, then maybe you have to excise. So it is chordectomy. And I will show you the clips, how it heals. So upon observing this, you will see the patient would be aphonic.
Vaporize the soft
But it's
tissue
not. There is a
to enlarge
neocord
the
formation.
glottis further. Use metal suction cannula as backstop to protect the trachea.
So interarytenoid area you have to remember, and adequacy of the excision. Okay. Now, when you expose any cartilage, perichondritis, so post-operative there are chances of granulations coming over. So you can, to prevent that, you can inject local hydrocortisone, or you can apply fibrin glue there to prevent the granulations coming over. You can apply mitomycin C. I have told yesterday, 2 mg per cc, 2 cc for 2 minutes. Now checking the glottic apparatus. Now upon doing the chordectomy, how you will know that this is adequate airway for the patient. Sorry, I will take maybe 5 minutes more here. Adequate airway for the patient. So what you do is take 5 to 6 number endotracheal tube. If you are able to pass that without any resistance, then that's the adequate airway the patient is going to have post-operatively. This is another method of lateralizing the vocal cord, that is suture lateralization, bilateral abductor palsy. Now suture lateralization can be temporary when you predict the recovery of the movement, or it can be permanent when you know the chances of recovery are less. If it is temporary, you just take a suture with Littenberger's needle, and maybe after endoscopic evaluation, if you see vocal cord movement has come up, you can just release the suture and take it out. If you want to do it as a permanent, then what you have to do, just do a raw area by vaporizing the vocalis muscle here and the vocal process, and then take a suture with Littenberger's needle. And when you take the suture, even if you remove the suture after 6 weeks, because of this raw area, this is what would happen. So these are the steps. Raw area, lateralized, this is the suture lateralization, and this is the result. So patient would have adequate airway with suture lateralization, but the problem is patient would have a little hoarse voice, because this is the entire vocal cord which will go laterally. Okay, so airway is better with suture lateralization, but there would be little hoarseness of the this one. Now already shown, but this is a case of fixation because of the web in the posterior glottis. Now this is the classification really which I have done of the glottic webs. Even if you see this web, you have to see it closely. This could be incomplete web. What does incomplete means? Ki if you go behind, there is the posterior glottis is paired, interarytenoid mucosa is paired. So this is incomplete. Now what advantage you can take? You can just pass in a bougie or a roller cord strip in the spared area, virgin area, then cut it with the laser or scissor also you can just cut if it is narrow, and you will find the vocal cord movement. Okay. So incomplete web in the posterior glottis. This is a complete web. If there is a complete web, then the raw area is going to heal again. Then there are multiple methods you can do, and laryngofissure, you can do posterior cricoid split and this one, posterior expansion of the posterior cricoid, or you can just vaporize this and put in the cricopharyngeal mucosa in between the two cords to prevent refibrosis of the arytenoid. Okay. This is after post surgery, so I have done laryngeal flaps. Now, okay, this is a prolapse which we have already discussed yesterday. This is a case with the prolapse and vocal cord palsy. So, I have done and removed the arytenoid. See the voice of the patient. Audio कुछ नहीं है क्या आज? Actually, she is a singer. See, अच्छा, thank you. See, her voice is quite good because I have done fat augmentation also and removed the arytenoid. Okay, same. Pediatric bilateral palsy. You have to careful not to be aggressive in pediatric age group, because these children may have aspiration in immediate post-op period. So maybe you can push nasogastric tube for 7 days to prevent any aspiration, because you are opening up the posterior glottis. Okay. Okay. Now functional outcome. Why I have showed you. You have made a cut over the vocal cord. The same patient. See, now this is on high-speed camera. This is pre-operative. This is 1 week post-operatively. There is some edema and a large opening in the posterior glottis. So patient would have a hoarse voice. Good airway, but a hoarse voice. Now same patient I followed up. Now see, you hardly see any opening there because there is a neocord formation, there is a fibrosis. This is on abduction, and see this is on abduction, so respiration, and this is on adduction. Now you see on adduction. See the mucosal waves. So mucosal waves are regained. There is a good fibrosis, healing. So it's adequate voice the patient would have post-operatively, plus this is the airway which is adequate for the patient. Okay. So swallowing, most of the patients would have supraglottic compensation and no patient would have aspiration. In my series, only one patient had aspiration for quite some time. Amongst maybe 600-700 I would have operated, but all other patients don't have any aspiration, because all the supraglottic structures, false vocal cords and everything, they take care of, compensate and prevent aspiration. So we do a FEES immediately after the surgery and after 1 month. These are the risk factors. Again, prevent injury to the interarytenoid area, or what would happen is the interarytenoid fixation and stenosis, very difficult to treat. Again, I have told this is a granuloma which can form after the surgery because of the perichondritis or the cartilage injury, arytenoid injury. How much distance? Again, I have told you. Now, before surgery, around 2 millimeters is the distance, and how you have to adequately get is 6 to 8 millimeters of the interarytenoid distance is adequate for routine day-to-day activities. Now, can you measure this on endoscopy? Yes, we have our high-speed camera on which we can, there are applications and apps. You can measure the distance also. But practically how you measure this, whether 6 to 8 mm would be available, pass an endotracheal tube, number 6, if it goes without any resistance, then it's an adequate airway patient is going to have. So these are okay. This is the dilatation. In the glottic dilatation, the balloons are always circular. So, and glottis is triangular. So I have put this slide. So when if you use only the balloon, it's going to slip into the anterior glottis and not exert any pressure in the posterior glottis. So what you do, take a bougie for dilatation, any esophageal bougie, pass it anteriorly, and posteriorly behind that you put in the balloon. So then it will apply adequate pressure over the interarytenoid area. This is just a, okay, there are release techniques. I think the future is there, re-innervation and all these things. Thank you. Yeah.
How do you counsel the patient? Many of your patients, I don't think there's a tracheostomy. They come with respiratory distress, breathlessness on exertion.
Yes.
And a good voice. So how do you counsel them and tell them, okay, your voice might go down, and after how many days does the voice recover?
Yeah. So I always tell the patient, immediate post-op, patient is going to have hoarse voice. First I will tell you all the procedure and everything. We are going to remove part of the vocal cord. So you are going to get good airway against losing some voice quality. That I would explain everything. My experience, immediate post-op, there is a lot of hoarse voice. I always tell the patient 3 months is the time. So 6 to 12 weeks, I always tell the patient you will have near normal voice. And actually we have recorded and we have published the paper also on post-chordectomy phonosurgical outcome, phonologic outcome. So almost all the patients have good voice.
Thank you very much, sir, for such an insightful talk. For the next talk, I would like to call upon the sage Dr. Anurag Ramawat for his topic, Innovative Method for Better Tracheostomy Tube Care in Peripheral Healthcare Centers.
Because you suddenly connected, no?
because there is already inflammatory reaction which has caused fibrosis there, not because of your surgery but because of the external trauma, and you are again reigniting the inflammation there with your laser. So if there is a bilateral cricoid joint fixation, don't do chordectomy, arytenoectomy. Straight away go for expansion laryngoplasty. Okay.
Good afternoon, everyone. Thank you, organizers, for this opportunity. And I thought Dr. Thiru would be talking about the tracheostomy, pediatric tracheostomy care, and before me. So, anyways, I will quickly touch upon the tracheostomy care. So, if you look at the topic, innovative method for better tracheostomy tube care in peripheral health centers. So one would think, okay, what is so new about it? We all know how to take care of the tracheostomy tube, especially even in peripheral health case, and we expect them to know. So, in a tertiary care institute like PGI, sometimes we get loads and loads patient only for the T-tube change or stomal issues, stomal infections, and we get patients who have not changed tube for a couple of weeks, because in the PHCs there is always a scare. I don't know, they have some kind of inhibition, especially in a pediatric patient, of regarding change of tube. They would say you go to the primary health center. They will just, so 20% of our minor OT procedure involves just the T-tube changes. So that's adding burden to our OPD procedures. Because as a tertiary care center, we expect only the referral and the procedure which cannot be done in secondary or tertiary care centers. So, I was fortunate to be a co-guide of one of the nursing student thesis that she evaluated how many children were coming to the OPD just for T-tube care, and then she got involved in teaching the attendants how to take care of the tube, which was done using a video. So then it struck to us, let's think of some innovative method, how to disseminate this expected, I would say, the skill we expect the caregivers or the attendants to change on their own when patients are on prolonged tracheostomy tube. So I'm sure every one of us is encountering these issues. So why T-tube care? So this is an interesting article I came across. I'm sure not all of us know about this. So even knowing how to do a tracheostomy and when to do a tracheostomy, that is a challenge. Although I was not aware of this fact until I went through the historical part. You'll be surprised to know, George Washington lost his life just because nobody was trained to perform a tracheostomy. So they did all those, methods which was in practice to think, okay, there is an airway issue, probably, some I think traditional ways to deal with, but somehow they lost it before they could actually think, oh, should we give an incision, should we do a tracheotomy, and the patient and Mr. George Washington had passed away by then. So complications of tracheostomy, we know it is in. Why I'm giving an overview of this, because we expect if in a secondary care center the tracheostomy is being performed, they should know what, until unless they know, they will not be able to manage it. So late or post-operative care. So how do you, if the patient is referred to it back to the peripheral health center or a secondary health center, how the main focus should be to keep the airway patent. That is why the track is there, So how to enforce that the the in situ tracheostomy tube remains patent. How do we educate them? How do we, convey this to the caregivers? So again, there are a few, key points to this tracheostomy tube care, that to keep it patent, it has to be humidified, it has to be changed frequently, the stoma should be infection free, and dislodgement again. So it has to be secured properly. So this is what we expect. So again, focusing on the life-threatening emergencies, accidental decannulation, tube placement. So by the time patient reaches you, we would have lost the patient. So these are very important, I would say, points that we should focus on. So how do we ensure that such emergencies can be managed where the accident happens? So if there is in the neurology, field of neurology, they have for stroke patient, they've got Red Alert app. So when a patient has these symptoms, it is alerted in PGI. They've got an alerting system. So there is an app already in place. So likewise, we thought of having a mobile app, where if there is an emergency which the periphery center cannot handle, we are being alerted. And then it is our responsibility to ensure by the time patient reaches or we have to ensure that initially the patient, we demonstrate to them through video or through communication that, okay, do this, go ahead with this. So this is the checklist, or, and then in the meantime, the patient can be transported. Even a small thing like just remove the tracheostomy tube. So the scare or the panic that triggers when the tube is blocked, you can imagine, a non-medical person facing that situation. This is an recommendations from an Australian group where they have in place, even based on AI, So these are the recommendations for the patent airway. How do we ensure? There's a checklist in place, which unfortunately, I don't know, ma'am, also if in India we do have that. Okay, so as I told you, what was the rationale of having this mobile-based app? I've already briefed you about that. In a peripheral health center, the caregiver may not be able to handle the emergency. So now, if you talk about the evolution of mobile health or AI, I would say Dr. I think Lau had briefly explained yesterday in his talk what is the role of AI in laryngology, so how it involved. So everybody's got smartphones these days, and we use a lot of apps. If you think, if you tell to a poor patients, do you think they'll be able to handle an app? But if you look at it, they're using so many apps left and right. So they're educated enough. You don't have to be, literate to know about how to handle the apps. They know better than us, I would say. So then came the mobile health or the M-health in place. In ENT, it is coming a little late, but in neuro and cardiac, because, arrhythmia, so that you can pick up the patient, the first few minutes are crucial. That's why this mobile technology is in vogue. So the different benefits of using a mobile technology. So I would just, if you look at it, the use of mobile health in tracheostomy tube care is to improve provider communication, that is the caregivers, when they're, living in a remote area and they have poor access to health centers. So, and we can also monitor, as I told you. US has been using, this is the app which has been developed in PGI along with the nursing faculty. So these are recorded videos. We have an app called NeuroCare. Under NeuroCare comes the tracheostomy tube care. So this is what we have proposed, a quality improvement initiative to enhance the quality of tracheostomy care provided by the peripheral. So what we are doing is we are looking at their skill first. So this is the objective. Start from, we evaluate their knowledge. Now the focus is towards not the caregivers. We are focusing on the paramedics. Paramedics, we expect them to take care of the tracheostomy. So we will evaluate, we are in the process of doing it, using a questionnaire. What is the knowledge they have regarding T-tube care? in case of emergency. And finding that gap of knowledge, we propose to train them based on evaluation. Then we have a pre-hands-on assessment where we're using mannequins to train them. Then we evaluate again their knowledge. And then again post-hands-on assessment. After the training, then we are telling them how to use the AMBASE application and then the implementation of the same. Although there are challenges, network access, internet speed, and we are also looking at in the back end how to work on this to do the troubleshooting. So again, as I said, we can improve on this AI-based tracheostomy care assistant app by including voice commands. Siri is already there, so it is not easy. We just to bridge that platform, and then the voice command can be given, because the illiterate patient will not be will be alerted to a tertiary care or the nearest healthcare center where we have chosen as nodal points. Available apps, there are apps already available. So this is already in place. This is again, I picked up from an article where they've integrated AI and the technology in patient care. It's a continuum, how we are supposed to do. So yes, this can be used, I say 65% of the growth has been observed. The use of mHealth or healthcare organization have also used this opportunity. It's been quite some time, including nursing officers, I would say. We need to train our paramedics and nursing officers. And we are aiming to incorporate this app into hospital service as an education module as well. It is hoped to boost the confidence, reduce anxiety among the caregivers, and in return reduce the complication rates, and leading to overall cost of healthcare, because the patient needs to travel frequently for simple tube changes. Thank you so much.
Thank you very much, ma'am, for such an engaging talk. And with that, we conclude this session on airway. We thank all our speakers and chairpersons for their valuable contribution. We now move on to the next segment of a panel discussion on pediatric airway. I would like to invite Dr. Kirti YK, Dr. Mudit Mittal, and Dr. Sandeep Sharma for chairing this session. Dr. Sachin Gandhi sir, Dr. Shashank Gupta sir, Dr. Murthy, and Dr. Rakesh sir will be the faculty on will be the panelists. And I would like to invite Dr. Thirunavukarasu sir for moderating the session.
Hello. We are just going to take a break from airway. Actually, there was a panel yesterday for management of early glottic CA, but most of the topics have already been discussed. So that panel, actually, I thought we'll have some practical tips which were not discussed, maybe few slides and clips and opinions from our senior panelists. And then pediatric airways, in last 1 hour we have almost discussed most of the cases. Only some few practical points we'll try to see through the clips and images. डिटेक्ट कर रहा है क्या वो? It's in the hard disk. नहीं, हार्ड डिस्क वो डिटेक्ट नहीं कर रहा है. Okay, we'll see जब तक वो होता है तब तक. Okay. ठीक है, वो नहीं बननी चाहिए. Okay. Do you have Shashank with us? Oh, Dr. Gupta is there. Okay, we'll just go ahead. We have already talked about, Dr. Murthy has already talked about the differences between pediatric and adult airway. So we'll just skip this. Now this is the question. Dr. Murthy, can you explain the difference between these sounds we hear from the pediatric or a child when they come in distress? A stridor, a strator, and a wheeze.
The stridor is basically arises from the larynx.
Prasun, yeah, you can join. Yeah, so basically upper trachea larynx, when there is an obstruction, patient would present with a stridor. So it's a turbulence of the airflow. Stutter is basically the upper, I mean in oropharyngeal, laryngopharyngeal area, when you get the obstruction, the patient is going to present with stutter. And wheeze is basically when it's a patient of a pulmonologist. This is the obstruction or the pathology is in the lungs. Now, just a practical question. What are the types of stridor and which patients you will get that particular stridor? The inspiratory, the expiratory, and the mixed one. Yeah. So this is the inspiratory stridor. This is typical inspiratory stridor. Here the expiratory stridor. And this is a mixed biphasic. Prasun, yeah.
So upper laryngeal, whenever there is obstruction, laryngomalacia or other conditions, we may get inspiratory stridor. When it's a lower tracheal condition, we'll get expiratory stridor. And something in between from glottic to subglottic to upper tracheal, subglottic stenosis, upper tracheal stenosis, we should get expiratory stridor. That is the norm followed.
Yeah. So I think up to the vocal cords, the supraglottis and vocal cords, it will be mainly inspiratory. As you go from the vocal cords below, expiratory, and if you go down, upper trachea down, it will be biphasic stridor.
Mostly at the thoracic inlet level, if there is a obstruction, you have a biphasic stridor.
Biphasic stridor, yes. So, I mean, on history itself or on seeing the patient, you know probably the obstruction is there. Okay. Generally these are classical because these patients are not brought immediately to your clinic. They have a stridor for maybe 3 months, 6 months. So when they come in the casualty, they are waiting in the casualty for 5 minutes. We take from our busy schedule to visit there. But just wait there for 2-3 minutes and you will see the typical nature of stridor. I mean, practically it may not be possible, but this is just to have some idea about the level of obstruction.
I just like to add, putting a stethoscope also will help sometimes to know where the airflow is maximum. So we should teach our residents to use stethoscope in the neck area to know the type of stridor.
Yes, yes, absolutely. This is just a clip. Actually, I showed you the laryngeal cleft. I showed you one clip yesterday, and this is, I mean, lower trachea or bronchi obstruction. So this is a cleft in the trachea going on into the left bronchi. See the cleft. See, there is a classical. And as you go down, in the bronchi, you will see it's extending down into the bronchi, the cleft. So actually this child, we counseled the parents and everything, and they decided to take away the patient with a tracheostomy. We don't know. Just a few points, how you evaluate the child in a, let's say, casualty, first 2-3 hours. Yeah.
History is the main important thing. We have to
Yeah.
ask the parents. So whether the stridor is the more during the sleeping or more during the activity. And
Yes.
second thing, when in a casualty, we can observe clinically the saturations and the phase of respiration where the sound is generating. So is it inspiratory phase or expiratory phase, and what are the accessory muscles, what are the retractions, all the things we can observe. Then
Yes.
in the next level, then there is a ultrasound guided, you can evaluate the larynx.
Yeah.
Sometimes you can evaluate the dynamics, or like some masses we can examine the ultrasound guided.
Yeah.
So after that, again you can go to the microlaryngobronchoscopy in a theater setup. Then if it is a tumor or it is a cyst or something like that, then we can do the MRI scan or CT scan with the contrast medium. This is the way to approach for this.
Yeah. So basically, when the child comes in the casualty with a stridor, it's very difficult to do MRI or a CT scan because they have to be under anesthesia. So I think ultrasound is the good thing because it can be done in the casualty. And I think still, because when I passed my MS, CT and they were not available at that particular time. And what we used to do is a X-ray neck. I think that's the best possible instrument you can just use. Just do the X-ray neck just to check the obstruction of the trachea.
And position of the child also is very important. It gives us the severity of airway obstruction. That's the first thing we look for.
Yeah,
And then
whether it is
meanwhile, while
supine.
we are examining, the rehab also should start immediately, like oxygen. Everything the nursing staff should start putting across.
Absolutely. Okay. Now you have to see the retractions, the pectus, I mean whether the retractions are there in the suprasternal area, in the neck, whether the failure to thrive. Again, you have to ask the parents whether there are signs and symptoms of weight gain. Multidisciplinarity we already have discussed. Okay, this is all three good. And what investigation we do is, again, we have Dr. Murthy has already told. Then once the child is stabilized with nebulization, with oxygen support, then you can do either awake flexible laryngoscopy if possible. If not, you can straight away take the child from the casualty to the operation theatre, and with the help of the anesthetist and their endoscope, which has a camera, you can go further. And CT scan, MRI, what I do generally is when the child is intubated during my investigation or in the operation theatre. So from the OT, we send the child to the for MRI and CT scan. So within that session, we get it done. Okay. Now management part, we have actually known everything. Okay, we have discussed. Now few conditions. I think this is not discussed in detail. The commonest airway obstruction would be a laryngomalacia. Dr. Porsun, how you will differentiate laryngomalacia clinically, a mild, moderate and a severe?
So depending on the presentation of child, most of these children will present generally after second week. They don't present at birth. After second week they present, and the child will be in severe inspiratory stridor. The stridor will definitely increase when the child is feeding in supine position. When we keep the child in prone position, we will feel some improvement in the child. If he has carried on with this laryngomalacia for say 2 or 3 months, he may also have a failure to thrive. So these are important points which we take in history, whether how severe laryngomalacia is and whether we need to a surgical intervention or just a conservative management.
Yeah. When you are going to go for surgical intervention?
When a child is having a severe failure to thrive, and feeding issues, then skeletal abnormalities, like because of the more negative pressure, the pectus excavatum will, this kind of the permanent skeletal abnormalities, when a child is reaching to this kind of the status, then we can do the surgical intervention. Sometimes if the child is having the neurological issues, so any central nervous system causes, central hypotonia. So if you do the only the supraglotoplasty may not be helpful in that situation, because there is a neurological thing is a long-term thing. In that situation, is a tracheostomy is the better one.
Yeah, okay. Now, we'll go step by step. So, because the laryngomalacia has not been discussed in our previous lectures, maybe we'll give some time for laryngomalacia. Now, mild, moderate and severe. Generally, the pediatrician would tell the relatives and the patient, I mean the relatives, ki let the child grow and it will subside. So, when you start telling the relatives, he may need surgery, they are going to ask why. So, you should know what is mild, what is moderate and what is severe. So, mild is intermittent stridor, not requiring any oxygen support. So, they don't require any support, it's intermittent. Moderate, when the child requires admission, maybe intermittent oxygen support. And I will show you before we go, as the investigation for laryngomalacia, because it's a dynamic condition, any static MRI and CT would not help. You have to do flexible laryngoscopy to see the supraglottic collapse. So it's supraglottic collapse starting from the epiglottis and the arytenoids, which are sucked in during inspiration, giving obstruction to the patient. And why this is important? Because those structures which are collapsing into the laryngeal inlet, you have to remove or vaporize, or you have to cut over those structures and take care of that structures as a surgery. Okay. So indications of surgical intervention, this is very important. Feeding difficulties, failure to thrive, so no weight gain, obstructive sleep apnea, and episodes of cyanosis. That's a classical indication. So you see the child, if you see he has not gained weight, then you know he may require surgical intervention. History of cyanosis and admission, another thing, and failure to thrive. So there is no weight gain. I think these three indications would suffice to explain to the relatives he may need the surgical intervention. Okay. Now surgical intervention, what surgical intervention you are going to go in for? There are three structures. One is the epiglottis, because we have seen in the clip. Second is the arytenoids. These are the two structures you have to deal with. Remove them from the airway to take care. Yes, Thiru.
So there are three types of the laryngomalacia, type 1, type 2, type 3, based upon the structures which are involved.
Yeah.
So if you have a epiglottis component, which is a long curled epiglottis, then we have to address the epiglottis, that is called epiglottopexy, where we are fixing the epiglottis to the base of the tongue anteriorly. So in that situation, we had to release the short AE folds. If you have excess mucosa over the arytenoids, which is prolapsing into the laryngeal inlet, then we had to address the arytenoid and the excess mucosa part. The cuneiform cartilage also need to be addressed along with the mucosa. So this needs to be customized based upon the situation. Sometimes the laryngomalacia will be unilateral. So in that unilateral, you have to address only one side of the hemilarynx.
Yeah.
So that
Shashank Gupta ko because Shashank is doing also doing a good work on laryngomalacia. Yeah, he is absolutely right. There are three types of laryngomalacia according to the structures which would obstruct the airway. Number one is the epiglottis. So posterior collapse of the epiglottis, that is number one. So to prevent the collapse over the area, what you have to do is suture this epiglottis to the base of the tongue, or if you have got the Littenberger's needle, you can suture it outside in the neck, and then you can release the suture when the child grows. Okay. Just to keep it permanent, what you have to do, like I have showed you for the vocal cord, make a raw area on the pharyngeal surface of the epiglottis and base of the tongue. So when you take a suture, that raw area would fibrose and epiglottis would not fall back. If the arytenoids are prolapsing with the mucosa, then you have to vaporize the mucosa over the arytenoids, so that will take care of the posterior extension. And just to open up the larynx, the aryepileptic folds which are short, you have to cut in midline. Now which instrument to use? I think scissors are also sufficient to take the cuts over the aryepileptic folds, because there is no major blood vessel at the midpoint of the aryepileptic fold. What post-operative care you would ask the patient to? Yeah. Yes.
So there are situations where we can do the apneic technique also. Because if only two components like RA epiglottic folds release is there, then it requires only a few minutes only. We can just simply do this procedure on apneic technique. If you are really addressing all the three components, this always requires intubation. And use the smallest possible endotracheal tube and put that endotracheal tube little deeper, because we are manipulating in the laryngeal airway. Sometimes it may be extubate automatically when doing the surgery.
Yeah, I think yeah.
Also, that the arytenoid, the soft tissue collapse of the arytenoids, since the endotracheal tube will come in the way, for that you always need a apneic this thing. And for epiglotopexy, since it is a long procedure, it's better to intubate and then operate.
So it's always tube in, tube out method. So first, when the child is in, ask the anesthetist to pass in a tube. Let the anesthetist be at peace with her or him. Then when they are able to ventilate, you are also sure that there is no obstruction down. Then once the child is ventilated, ask them to remove the tube. Meanwhile, you just prepare your instrumentation, and then you do whatever you want to proceed with. Now, which cases you may not, what are the chances of failure? Even if you see classical laryngomalacia, you have told about it. In which case it may fail this surgery? It's a laryngotracheomalacia. So when there is a tracheomalacia along with laryngomalacia, then only operating on the larynx may not suffice. Patient ultimately would go to tracheostomy. Why this is important? Because you have to explain to the patient that the results are 90%. What happens to remaining 10%? That you have to explain. Thiru is also there with us. Hi Thiru.
Hi sir.
Hi, yeah. Yeah, Thiru.
For not able to join you in person.
Yeah, sure, welcome. Yeah. So Thiru, we are just discussing laryngomalacia, and I was just telling them about the adjoining tracheomalacia. The tracheomalacia, but it's not that commonly seen in India, but you have to be aware about this, about the failures. Yeah, Thiru, any points you have to add? Yeah.
In that case, if they are doing only laryngomalacia surgery, it may not be, good enough for the child to recover. So that is one important point. Another thing is, in case there are some neurological issues associated with majority of the children will have neurological issues and also some pharyngomuscular incoordination. So in those children, if you do surgery, then the results may not be good. And some of the syndromic children, if you do surgery, then the results may not be good. So you will have to choose the patient, based on the symptom and also based on the other concomitant lesions. Then only we can get a proper, complete result. In our study, overall, if you are doing surgery for failure to thrive and feeding issues, those children are, having fantastic results after surgery when there are no other problems. And in our series, there are, in case if there is neurological component, still we have no other option but to go ahead with the surgery, then the failure rates are very high.
Yeah, good. Nilanjan, how you will manage this post-operatively? Yes, you have done the surgery. It's 15 minutes job. Just cut the arteriolytic folds and this one. Whether you will keep the child intubated or you will not keep the child intubated.
Hello. Yeah. I would prefer to extubate the child in the OR itself rather than, I would of course keep the child in an ICU setup later on for monitoring, but I would extubate the child on table. Intubation or prolonged intubation tends to actually cause more problems rather than good for these children. Usually post laryngomalacia surgery, these children tend to recover quite fast.
Yeah, person.
I have a little difference in the point because the idea that we are doing this is we are cutting and we are waiting for the fibrosis to happen. We don't expect it to happen immediately. So at our center where the volume is not very high, it's once a month. We keep the child intubated for 1 day in PICU and then extubate, keep the patient on HFNC, and then on third day we start child on regular monitoring. So it can vary with institutes.
Yeah, Thiru.
Yeah, I mean, this is based on the case by case basis. Some children we extubate on the table. Some children we intubate. Like they said, in case if there are raw area being created in the tongue base and the valvula.
Yes.
In that case, we may intubate the child to keep the epiglottis close to the raw area for 1 or 2 days and then extubate. But in case if we are doing a supraglotopexy like in Littenberger career and suturing it, that situation you don't have to intubate the child because anyway this is being pulled up. So we will intubate the child on the table and send the patient
Yeah.
to the ICU.
Yeah.
But anyway, we'll keep the child in ICU for a day at least for observation, and then the next day we will bring it out to the ward.
Yeah, I think it's not only the surgical manipulation, it's tube in, tube out method. So anesthetist has to put the tube maybe 2-3 times, remove the tube. So that also would cause some laryngeal edema post-operatively, laryngeal tracheal edema. And the anesthetists are headband to keep them intubated for 2 days. So basically number one, if you are indulging in multi-level like epiglottopexy, arytenoids, then maybe it's better to intubate for 48 hours, 2 days, keep them in NICU, PICU for 2 days, at least 2 to 3 days, extubate after 48 hours. If you are only cutting the arteriolytic folds in the midline, which is done in around 60 to 70% of the cases, then there is no need to intubate and keep the child in the ICU. But see, all this, why I am telling you, this has to be told to the relatives well ahead. The chances of success, because first thing they say ki child is small and listen. So chances of success, if it fails, why it fails? If it fails, what we are going to do? So I always tell, we'll extend the stay in the ICU, maybe put in the tube again, and if 7 days again after removal of the tube, the child continues to having this, then we'll do tracheostomy. So this has to be explained to the patient. The cost of ICU, your surgical charges would be 50,000, but the 1 day stay in NICU would cost another 30,000. So this has to be told to the relatives well ahead how we are going to do, because every child is precious. Now coming over. So I think these two things we have to remember about the intubation and post-operative care. Just tell me a post-operative complication which you should be worried about.
Aspirations are most common thing.
Uh,
While feeding,
Maybe.
feeding issues.
Maybe what's the most severe complication? Thiru?
Yeah, the most dreadful complication is that supraglottic stenosis.
Yes.
If you're making raw area in the medial aspect and going into the inlet, then there is a possibility of supraglottic stenosis. And also sometimes what happens in one of my cases, what happened, the stenosis happened on one side. So the epiglottis was pulled towards one side of the arterioepiglottic fold. So that what happened, because of that, the epiglottis is almost like occluding the supraglottis, something like a supraglottic stenosis. So I had to redo the surgery, release it again, and this time I had to pull the epiglottis up, create a raw area again, and suture it, and then it became all right. So that kind of complication will be dreadful, and that will happen little later when the patient is at home. So you have to be really worried about that kind of situation when the child is at home. So
There is absolutely right, supraglottic stenosis, because it's a small larynx, you are making the cuts along the line of the epiglottis, the areoplatic folds, arytenoids both. Okay. Again, Nilanjan's point. Now in the USA, most of the, I mean, I told about 70% would require cuts. Maybe they are going early diagnosis. 90% of the children, they cut only areoplatic folds. So now laryngomalacia has been done as a daycare procedure in many of the USA centers. So I mean, just think about all these problems and practicality of the surgery. And when I started this, it was quite a new in the world. So I used to do on one side, second stage on the other side, and usually the procedure has explained that first you have to tackle only the areoplatic folds. If it doesn't suffice, then second sitting on the arytenoids. If it doesn't suffice, then I used to do is in my initial days, maybe 20-25 years back. But then patients doesn't like this, they can't afford this. Anesthetist definitely it doesn't like this to take child under anesthesia again. So better to diagnose it well before with the endoscopy, the types of laryngomalacia, and manage and plan your treatment. Yeah. You should come ahead, Ravi Kumar. Rajesh Kumar. Rajiv, yeah, please. Okay, valvular cyst we have already talked about in detail. Just a congenital valvular cyst. A child comes in OR. You just put in a laryngoscope, you see this valvular cyst. The valvular cyst during inspiration would...
Can we see the presentation?
Yeah. Okay. So how will you manage? The child is in stridor, in the OR. You have put in the laryngoscope.
So in these cases, intubation becomes difficult. So before intubation, we just aspirate the fluid, intubate the child, and then with a coablator or laser, we can just marsupialize the patient.
Actually, this skill I just want, because this
I've learned this from you, sir.
Yeah, and this is very useful, because anesthetists, I mean, you have to be careful about them. We have dealt with this quite easily. Laryngocele also we have seen yesterday. Okay, this is just maybe, this is actually a mass in the or the arytenoid turned out to be laryngeal lipoma, so we are able to excise it quite clearly. Another congenital internal laryngocele, if it is having external as well as internal component, how you do the surgery? Nilanjan. Because Nilanjan, I have done, I mean, one external approach.
We'll have to do an extra, exactly what I was saying. We'll probably have to go ahead and do an external approach, because otherwise this does not come out in toto. If you, there's probably another idea could be that tackling the internal part endoscopically and then do an external approach for the external part. But then I think with an external approach you can get the cyst, the seal, laryngocele completely out.
Yeah. So I think this is after the surgery, and these children are really troublesome. Intubation has to be careful, and external surgery is the best. And actually, let me listen. I called Mark my Rutter a few years back for our LVA conference. It was in Goa, and he showed me 3 cases of this external approach. Just do that, and we did one, and the child actually did very well. So these are not difficult things to do, really. Any institution you can just approach, but you have to do with the endoscopy and maybe imaging. First diagnose what is the differential, and then go ahead. Yeah, please. Your experience also would be important.
Regarding this, sir?
Laryngocele in a child.
So as you told, if it is external component is there, sir, we have to go with the open approach only.
Yeah.
As Dr. Nilanjan was saying, because complete excision, if we are not doing it, it will recur sooner than later. So that is very important.
Yeah.
I just want to add one more point that
Please,
you discussed before, laryngomalacia with tracheobronchomalacia, sir. So as you were discussing that, but we have a prospective study done and published in our department by Dr. Prem Sagar. She is a professor and pediatric otolaryngologist, So they done 28 cases, referred from pediatric ICU. So there is supraglottoplastis and like types, and they found a mean reduction of 41% in lower airway, tracheobronchial components also, and they are able to extubate those patients. So I will share that paper in the group also. So in patient with laryngotracheobronchomalacia, it's a dynamic airway and there is an inspiratory stridor leading to a dynamic collapse lower down. Supraglottoplasty in our experience have made a significant improvement in the lower airway, and patient will be able to extubate and decannulate also in certain cases. And in very severe cases, then only we should practice the PEC component with the thoracic surgeon. But it can be used as a first line of treatment for patients rather than going directly for the external component. I will share that paper in the group now.
Yeah, that's fantastic. Yeah. Manjunath, you just asked this Bharat also, and because they will be thinking about 2 o'clock panel. So if they are outside, I mean, just if somebody can just pick up those two and just ask them to join us. And okay. I think we have discussed this yesterday. Laryngeal papilloma also has been discussed. Just one point. Generally, when we pluck it and remove it, especially from the anterior commissure, there is a bleeding. What you will do? A small larynx, patient doesn't have a tube because you have asked the anesthetist to extubate, because you have to pluck the papillomas around. So anesthetist bleeding. So what you will do?
So whenever there is a bleeding, what we use is a neuropathy or cottonide with the adrenaline, and just keep a little pressure for 1 to 2 minutes and wait, and it will resolve because it's just a mucosal. It's a bleed. No cautery, nothing should be used. Just a neurocorticoid.
I think this point I wanted to get. Just keep a neuropathy and wait for 1 minute. No surgeon can sit down for 1 minute, but you have to wait for a minute. Because why this happened? Because our sisters, they are used to arytenotomy, all this thing. Mama, cautery lagao, cautery le lo, ye lo, bleeding dikh raha hai. So don't put cautery on the vocal cord. Just keep a neuropathy at lens hook. He has rightly said, wait for 1 minute and it will stop. Just start plucking the further papillomas. Okay. Okay, you have seen this clip by Thiru. Dr. Reddy, how will you manage subglottic hemangioma?
Subglottic hemangioma, say in a proliferative place, if you can give the propranolol, it is going to be helpful. If it is a mature, like a long-lasting chronic hemangioma, subglottic hemangioma, with occluding the most of the lumen, then we have to take up for the surgical intervention. This can be transorally through the with the help of coblation or a laser.
Well, before going to surgery, are there any surgical methods? And if they are, Thiru, are you here?
Yeah, yes, sir. Yeah.
Yeah.
Everyone used to do a lot of surgery externally or endoscopically, but now almost all the patients respond to propranolol very well.
Yeah.
So it melts like anything. So almost every single patient we start on propranolol and giving him propranolol for a longer period, then it will be sufficient. And some of the children, when the children are presenting with a very acute phase, maybe you can give short course of steroid as well, and that will be sufficient enough. No, I don't think anybody is doing surgery for subglottic hemangioma these days.
Yeah. So I think propranolol and steroids. Yeah. Pediatricians to give, yeah, because the presentation age differs actually. When actually it's not that obstructing. If it's obstructing, patient has been referred for airway obstruction. You put in your scope and see the obstructing hemangioma on imaging also you feel. Then you may, you may means you have to go surgically. What I have put this clip intentionally because you can see the airway here. It's not completely blocking the airway. So this, you have to give trial with propranolol, steroids, and then think about the surgery. And if it is breathlessness, the child presents on this one, then you have to go surgically. Yeah. What surgery
Just
you
a
will
point about the dose which they asked. Generally, our pediatricians give 0.25 to 0.5 milligram per kg. Even that high dose, they continue even for 3 months. So we feel that it is too high for child, but they are very open in giving a high dose propranolol. No, that is just for 2 to 3 weeks they give for the, as sir said, acute phase, and then
Yeah.
for the propranolol continues for longer duration.
Yeah. What, I mean, how do you remove it? Surgically? What instruments you will prefer?
For hemangioma, sir?
Yeah, if you want to remove it surgically.
But as sir said, we hardly do any surgery. We do propranolol therapy only.
No, that has failed.
Yeah.
Patient has now stridor. So you have to remove it surgically. If it doesn't subside with your medical line of treatment, then what instrument you will use?
So best way then we use cobbleters, sir. Then because it will be less bleeding. It will be only done when it is in a mature phase and failed propranolol therapy.
Yeah.
Cobbletor is one option, sir. That can be safely done these days. Some people use laser also, but we have no surgical experience per se because most of our patients have always responded with propranolol therapy.
Yeah.
So for my patient, one of my patient didn't respond and presented with a severe stridor. Then I had to do with coblation assisted subglottic hemangioma excision. Then simultaneously I put her on a propranolol also.
Yeah. So I think either you use compilation or because I am a laser man, a diode, KTP or blue laser, because these are all hemostatic lasers. They work on hemoglobin in the blood vessels. So I mean these options are available. Non-contact mode application of the laser. Okay. Okay. Now this is a case, a congenital subglottic cyst. How we will intubate? I mean, you have shown this to the anesthetist. I mean, any idea? You have to do the surgery.
You have to do this with a apneic technique only. You cannot
Yeah.
intubate. If you put a tube, you cannot see you cannot access to the cyst. Sometimes cyst may rupture and gives a lot of mucosal tags. Again, it will cause a secondary subglottic stenosis. So always I prefer this one doing in an apneic technique.
Yeah. Only thing is in children, apneic technique is little difficult because they don't hold on for more than 30. Maybe during a first access, maybe they will hold for a minute or so. If you intubate and extubate and again do surgery, then they will not hold for more than 30 seconds. Then the desaturation is so rapid. I mean, I just want to know about any other alternative method of anesthesia. So this you can use jet ventilation.
Jet ventilation, if it's not available, you can put a feeding tube, so which will connect to the oxygen flow.
Yes.
5 to 6 liters you can put in the nasopharynx. It is increasing the concentration of oxygen so that you can do the surgery.
Yes. So
this,
I mean,
this is the method what I am following here because I don't have jet ventilation, and also there is always barotrauma is always we should be
absolutely.
keep in mind.
Yeah, but we wanted to know this method, your method, and that is very important for where it's not available. You see this clip and then you are worried how to intubate. Then anesthetist would ask, then they will ask you to do the tracheostomy, and you know patients, when I tell them tracheostomy, they just take a discharge. They said, why we have come here? Because we have heard that the tracheostomy is not in here. Patients relatives are very smart these days. Okay.
And here in this case, there are both sides of the cystic lesions are there. First address with the major cyst, rather than addressing the both sides.
Yeah.
Maybe second side after 1 month, once this is re-epitheliage, then look for a second look. If the cyst is bigger, again you can address in the second side rather than addressing the both sides.
Yeah. Just because you have come up with this, if it is on both the sides or if it is a edema in the subglottis, and you have to do it at one go, I mean only one sitting, then how will you go? I mean, of course, because I have a laser, I will just do it submucosally. So like we do for the turbinates, we prick the turbinates and we with the cautery we pass the heat submucosally, so the terminates actually are retarded. So this patient, if I want to do it in a single sitting, what I would do, take a laser, push it in the cyst, apply there, so it will collapse, and then apply do on the opposite side. Just because I just
And one
remembered
more
this.
point, see, after doing the cyst excision, you can just do the balloon, keep the balloon that dilate it.
Yeah.
It also will helps for the other side.
Yeah, absolutely. And you can inject steroid also for the other side. The other side may maybe come up because of the contact of this. Yeah.
Yes.
But this is what we have learned is the method of anesthesia. Just take a suction catheter, through it you can just take 2 minutes, what are very important for you to take out the bigger cyst. Yeah. Okay, this subluxation, everything we have seen. And again this supraglottic we have already seen. And again subglottic stenosis. Thiru? Subglottic stenosis, how will you classify and how will you? So this is a membranous cyst, though it is grade 3, it's membranous. So what you will do?
Yeah, I mean, this is congenital stenosis, right?
Yeah, congenital, yes.
Yeah. So congenital stenosis, most of these will be like, the glottic web extending down to the subglottis. So Cohen's classification, like type 3 and type 4 will have subglottic extension. So when you see, there will be only the thin web kind of stenosis you will see. But if you carefully examine, there will be extension down because of the embryology, and the stenosis will be in the subglottis. So we have to exactly see how far down it is going and do the scopy with the rigid telescope. Sometimes if you want, you can do an angular endoscope to see the just below the anterior commissure how far down it is going. But most of the time it will be like a boat shape, and it will go down up to the level of the lower quarter of the cricoid cartilage. And that situation, you cannot try anything endoscopically to release the web. You will have to do only the open surgery, and most of the time you have to put an anterior graft, and most of the time it will be double stage procedure.
Raju?
So, sir, it's a membranous web, so it will be easily excised with the laser. You can use CO2 laser, or you can use, some people these days are using coblation also for thin webs, that is acceptable. And then if the subglottis is not very edematous, then you don't need to do balloon because it's web only, and it will be resolved.
Yeah. So again, clinically, if you are able to see with the endoscopy through the web, the tracheal rings, then they are membranous, then you can cut with scissor also.
But
if you are not able, yeah.
Most of the times it looks membranous, but it's always better to get a scan or something.
Yes.
Because
that is very important.
From the endoscopy it looks membranous, but there will always be, like Thiru said, always subglottic extension in Cohen type.
That's the point actually I wanted to, and he has
don't
told you rightly. Even if you get this clinical picture, do a CT scan. There are two types of webs, membranous and cartilaginous. If it is congenital, most of the times likely to be cartilaginous. So you do laser and they will come back again. So for them, you will have to send it to Thiru or Murthy or this one to do laryngotracheoplasty or extended, all the open procedures. Okay. So CT and clinical endoscopic visualization is very important. Now, we have seen this again, Mercedes base incision and dilator. Now dilator, I have told yesterday, when you are using a balloon dilator, check the pressure which is allowed. It is always printed on the cover of that package. Don't exceed that, otherwise it will give microfractures of the cricoid cartilage and unnecessary the problems. Okay.
And to know how much to dilate, there is an app from Cincinnati Children's.
Yeah.
So that app gives you like for what age, how much you have to dilate. So it's always better to keep that app on your phones.
Yeah. Now this last slide. If the child is intubated in ICU and you get a call in the midnight, ki saturation is dropping, and come immediately, you will have to explore the patient again, and what you will do? Yeah. So care of endotracheal tube and tracheostomy tube. Yeah.
So depends on what surgery we have done and the patient has
No,
been,
no. This is, you have done some surgery, you have intubated the patient. This is what my experience I am telling, but you have to remember this.
So most
this
importantly,
point.
there might be a block, or mucosal block might be there. So
No,
use a
that
good
all, because this is NICU and they are all trained.
Change the tracheostomy tube or endotracheal tube, that also.
I have again told you, first and foremost thing is X-ray chest. When the child has some problem, ask the intensivist to have a X-ray chest done immediately. And this X-ray chest was done. And what it showed, the endotracheal tube touching the carina. And what that NICU intensivist asked her to do, just remove it a little bit, and that's all. You have to remember this, because all these neonates and these are going to have these problems, and you are going to have a call in the midnight. Everybody is in panicky. They just intensively phone the pediatric surgeon. This, that, there was a rush. So, and another thing, yeah.
So just want to add, like X-ray chest, you said that is very good investigation. We can simply put a pediatric fiber optic through the tube itself and look for this.
Yeah, absolutely.
In the middle of the night, NICU may not have the pediatric tube, these endoscopes. So it will be there in the theaters only.
Most of
No,
the
no,
ICUs have
all
now.
ICUs have fiber optic these days.
Most
Our
of.
ICU have.
Yeah.
So even our
Yeah,
residents in the middle of night in ward
They can
itself,
do,
we
yeah.
can do fiber optic
Fiber optic.
for every patient.
Yeah,
Okay,
this,
that might be-
why I have this, because I have undergone, you have to just remember, and tracheostomy care, a low tracheostomy in a child. कौन देगा? Nilanjan knows, so I will not ask him. Yeah, Murthy. What complication you expect and how you treat, manage this?
So low tracheostomy, the shaft of the tracheostomy tube will go into the one side of the bronchus, maybe block the other side.
That's number one.
Second thing is, because of the multiple times suctioning, and gives a granulations, bleeding thing, and block the tracheostomy tube. And third point is maybe aberrant innominate artery. The chances
That's that I wanted to know.
But
Yeah.
nowadays we are using all Portex tubes only, may not cause that much. If you are using the metal silver Jackson tubes, there is a high chances of innominate artery damage.
See, low tracheostomy, if it is maybe within 3 months, even if you Portex and whatnot, this child may have innominate artery rupture, and what is the treatment? There is no treatment.
No treatment.
Child is going to die. Okay, so you have to remember, low tracheostomy, you have to keep it up, keep some package there, and be ready with all these possibilities in mind, because I have lost one child. That's why I have put this as a tracheostomy and endotracheal tube care is very important.
I have a small experience.
Yeah.
Innominate artery, they bleed. So I am there in that situation. What I did, I put a finger, this is adult patient, not a pediatric patient. I put a index finger into the trachea, put a pressure against the sternum, then took into the theater.
Yes.
So in that way, I could able to save the patient till they open the thorax. Then I just put a finger there only.
Yes, there are
That is
ways
one.
to do that also, but you just have to keep this.
Yes.
Low tracheostomy, just keep this point in your mind. This may bleed. Thank you.
Thank you.
Please, yeah.
FOL in a 2-month-old or a 3-month-old child, you said awake FOL. So do you use 4% or directly just directly put the scope?
Identify नहीं हो रहा. I don't know.
Most of us,
Or 10%?
No, please.
we just mummify the child with a large bed sheet, and somebody hold the head. Mostly the mother or the father hold the head, and then we pass the tube, because patient may not allow putting the spray. Any other experience?
It's always a good idea to do airwayscopy in the OR, ideally.
We are doing in OR only. That's why I asked if you're doing it in the OPD
Decongestion,
or the NICU.
decongestion of the nose, and then I think that would be the safest way. Thiru, I think that is, what do you feel?
Yeah, I mean, like you said, I always do the scope only in OR and whatever the scope we are doing. So first, I start with awake endoscopy. Most of the time, we'll give little bit of 1% flow rate for the child to sleep little bit, and then we start in case if we have both end of flexible laryngoscope or bronchoscope, we can inject a little bit of 2% xylocaine, or maybe you can dilute it as 1% xylocaine, 1 ml, spray it over the cord, and then pass it down. So that way you can minimize all the problem of that, spasm or anything. Most of the time it will be possible that you can do it. And also when you see all the dynamic assessment, then you want to cross over or go down, and that time you can ask your anesthetist to deepen the anesthesia with propofol or something, and then you go down. So we don't use 4% xylocaine or 10% xylocaine at any point in time. So the 2% xylocaine which is used for injections will be good enough for children's topical.
Yeah, I think awake endoscopy, number one, we are doing as old as 1 day old child, we are doing in voice clinic. So you have to have that endoscope with you, and just some trivial nasal drops, and that's all. That's number one. You get a good recording. The child cries, so you see the dynamic movement of the vocal cords and the airway. Maybe you will not able to go down into the trachea, but yes, supraglottic and glottic you can definitely see. If you want to see the subglottis, then as Thiru said, take the child into operation theatre, take a sinus endoscope with you, 0 degrees adult sinus endoscope, take the Macintosh of the anesthetist, give propofol, lift the base of the tongue, see the vocal cords and everything on the monitor, so every anesthetist and everybody, and record it so you can discuss with the relatives. Just spray some xylocaine, and then you can pass in below till the carina and see the trachea. So I think the sinus endoscope has helped me a lot.
And do you use after any laryngeal surgery, are you using lock spray in adults? Many times we use before taking out the laryngoscope. Do you do it in pediatrics also? Or you don't do?
Actually, I don't know, I could not understand, but number one, pre-operatively we give nebulization with xylocaine, and post-operatively as soon as the surgery is finished, when we remove the endoscope, before removing the endoscope, our mama actually sprays the vocal cord with the spray.
Okay.
I mean, that's regular we do. I mean, let me introduce this. I was waiting for him because he's doing good pediatric air work, laryngomalacia in UP. Yeah, please introduce.
Yeah, I'm Dr. Shashank. So I got your question. I do all my cases under total intravenous anesthesia with spontaneous respiration. So always we spray first also, because we don't want a laryngospasm, 10%. If the child is below 3 months of age, 1 spray is enough. More than that, 2. And after 1 year of age, you can do 3 sprays. So it's usually according to body weight. But because laryngospasm is, the chances are higher if you're not giving a muscle relaxant. It is always better to spray. Second thing, this is for surgery on the cords or in the airway, but even when you're removing foreign bodies, always spray first. It gives you a lot more time in the trachea.
Just explain you what instrument you will use for surgery of laryngomalacia.
So I use, classically we use the anesthetist laryngoscope, the Macintosh. We place it between the base of tongue and the epiglottis, we lift it up. So my assistant is holding it, or sometimes even my anesthetist holds it. She's comfortable with that. And I use a classical 0 degree 4 millimeter endoscope, the one we use for the nose. You get plenty, the vision is good, you get a wide field, and you can go right up to where you want to operate. The instruments are the classical adult MLS instruments that we use.
Okay. And anything you have to tell about your experiences of laryngomalacia.
So, sir, I was listening to you online. Manjunath sir called
that's
me
good,
and I was
yeah.
like, I'm running back.
Uh-huh.
So, I opened it up. So, the thing is, when laryngomalacia, we have to address three things like the lax mucosa, the tight folds, and the epiglottis. So, sir was saying ki initially I used to do one and then counsel. And that is what the Americans also keep saying. Ki just do one thing and then take up the child again. In India, that's not possible. That's not practical. So, a very good diagnosis, obviously a good scopy, but it is always good to address all three. There's no harm in doing it. The last thing you want is the child coming back to you with a floppy epiglottis because you did not address the epiglottis. And then they will start questioning whether your diagnosis was correct or whether you did something or not at all. So always, and there's no harm, just address the epiglottis, glossoepiglotic fold, cut the aryepiglottic folds and take off the mucosa. You'll always end up with a wide larynx.
Yeah. And
when the epiglottic fold is cut and you're also chopping off the loose redundant mucosa over the arytenoid, some people leave a small island of normal mucosa in between the two cuts.
yes, that's you have to, yeah. That's you have to do, just to prevent. And just to add to it, that's one advantage of keeping the child intubated for 2 days, just to prevent the adhesions. See, you have to remember, I have done maybe more than 500 cases. I still have not gone into that case, but I have taken one image from the internet of the supraoral stenosis. You have to remember this supraoral stenosis, yeah.
In OSA case, in a pediatric, always evaluate your larynx. I had one patient, huge adenoids, I did adenoids, then rapid maxillary expansion. Then also the child was not, then we looked into the larynx, then there was short AE folds, only short AE folds, not much of arytenoid epiglottic collapse. Then we released that, then the child became all right. So I think
Actually, that's what the literature says, that 4% of laryngomalacia cases will present only with OSA. We don't get that kind of numbers, but that is what the literature says.
Yeah, good. I just wanted him to have, because I think he did fellowship 2-3 years back, and he started in a peripheral center. So it's not a big institute we boast of. So that's why it's quite good for all of us to start with the surgery of laryngomalacia. Yeah, please. I mean, that's the sad part, because I'm boasting of my 10-12 fellows presenting papers there, but the part is I'm becoming poorer and poorer every day with more and more fellows doing this kind of practice all along India. Again, we'll go to translator laser. The points which have not been discussed. No, 5 minutes. Acha. So you have to ask them? Okay, no problem. I think we'll finish in 5-10 minutes. Only points which are not touched.
We now conclude this engaging panel discussion on pediatric airway. So our sincere thanks to the moderator, Dr. Sachin sir, all our panelists for their valuable inputs, and to the audience for their attention. As a token of appreciation, we would now like to invite Dr. Sachin sir to present a token of appreciation to Dr. Mudit Mittal.
I would like to thank all the panelists and Dr. Thiru to be here. Yeah. Thank you.
I would like to call Dr. Shashank sir. Dr. Sandeep Sharma, sir. And Dr. Kirti, sir. Ma'am. Sorry, Dr. Kirti, ma'am. We shall now start with the next panel discussion on early glottic carcinoma. This will be moderated by Dr. Sachin Gandhi, sir. And I would like to invite our panelists, Dr. Bharat Panuganti, sir, Dr. Harishankar, sir, Dr. Shantanu, sir, Dr. Rakesh Kumar, sir, and Dr. Sameer Newsarkar, sir. I would also like to welcome Dr. Sanjeev Yadav, sir, and Dr. Suma, ma'am, to chair this session.
Just to finish, I mean, Dr. Samir is? Okay. Okay, then I think let me show you some clips and that's all, yeah. Can you just project it? Projection? Yeah. Just history, I mean, just short point, I will just go fast. So it started with punch forceps, then cryotherapy, cautery, and now different types of lasers. So basically two things, it should be a mid-cord lesion, ideally for laser. It started with mid-cord lesion, then extended chordectomies to all other things. And then for a patient with acute respiratory obstruction because of the mass. So just to prevent a tracheostomy, you have to go in for laser ablation of the mass and open up the airway. Okay, so this is all is discussed. I mean, if it is extending for more than 1/3 on the opposite cord, more than 1/3 of this on the opposite cord, then you have to go in for radiation. So that against doing transoral laser surgery. Now, posteriorly, if it is involving the arytenoid cartilage, then it should involve only the vocal process and not the body of the arytenoid. Okay. Then if it is involving, then you can do 5A or 5B chordectomy, and this is after the surgery. So this is, I mean, this is a good picture. We did this last week. So this is the vocal process and involving the vocal process, not extending towards the body of the arytenoid. Then if it is going into the lateral end of the ventricle, then you should go in for, send the patient for radiation. So basically 1 millimeter is safe margin. How is 1 millimeter? I am also looking into the microscope. You are also seeing. So just have the idea. So this is 1 millimeter. This is AccuBlade of 1 millimeter length. So I just wanted to just mark it and show you what is 1 millimeter. So this is a growth here. This is the margin of the growth. From that 1 millimeter. And you have to also palpate for the induration. See now I am just joining this 1 millimeter marks, and this becomes your incision. So this is the 1 millimeter margin, sufficient oncologically and for also pathologists to report. The thermal damage to the surrounding tissues, because CO2 laser is absorbed by water, so it will not go laterally. Plus it gives plane and everything. Or you can exercise the false cord like here, and then you have a good exposure of the lesion. So I exercise the false cord, and I can see now the lesion quite clearly, the lateral area, the anterior and the posterior. So you should have everything, and then you have to, this is for phonosurgery, When there is a polyp, nodule, whatever pathology it has, you have to mark the incision first. Don't start excising. Mark it first. All the margins, anterior, posterior, under surface, and then start excising. Then after excision, then clear the char tissue, and again you have to examine with 70 degrees whether your excision has been complete. The anterior commissure, laterally, and the under surface of the cord. See, under surface of the cord with a 70 degree sinus endoscope. See, so it's complete. So you have to check it. See, these endoscopes are available in your clinic. Sinus endoscopes. Just take them and examine. Okay, so this is type 1 choroidectomy, epithelium, CA in situ or keratosis. This is after surgery. CA in situ. Type 2 is the lesion. And type 2 choroidectomies. This is before surgery, this is after surgery. Good approximation, good voice. Because the patient has got good vocalis muscle, there is always a good approximation. So type 1 and type 2 choroidectomies are itself phonosurgical procedures. So no need to do any correction for these two choroidectomies. This is type 2 actually you are asking, but I will show you in the break. Yeah, the choroidectomy. This is post-op. This is type 3 choroidectomy, in which I have removed bulk of vocalis muscle. So this patient is going to have phonatory gap after the surgery and would need some correction. So what we are doing is put in a, this is type 4, in which there is a, actually I have gone up to the thyroid cartilage. So big phonatory gap here. So this patient would require thyroplasty. And other patient has some vocalis muscle, so would require fat augmentation. So this is the patient. Growth here. This is after choroidectomy, and I have checked within the operation theatre. It's free of tumor, margins are clear. I have injected the flat. This is immediately post surgery. This is the fat augmentation. This is after 12 months after the surgery. This is his voice. So even if the phonatory gap is good, you can correct it. Utilizing thyroplasty. Okay. So you just go fast. Type 5 we got it. Limitations are like these patients. No exposure, no good exposure. You can't see the lesion all along. Trismus, short neck, obesity, retinocratia. Then for these patients, if the growth is small, you can do KTP laser endoscopic application. So these are all our published papers, including fat augmentation, high-speed camera, and everything. So these are established methods, and you have to tell the patient is well ahead. This is possible. Just get rid of your cancer first, life-saving, and then voice would come back. Don't worry about that. Okay. Okay. This is one case. I'm using Da Vinci robot. This is KTP. This is angioma of the larynx, supraglottic angioma with the KTP laser. It's a growth in the anterior commissure. This is laser safe tube. This is a CO2 laser fiber. So every instrument has got its advantages, and I think if it is possible, you can always vie for it and get it into your department. And we have learned about this cytoendoscopy and this one. Many youngsters were asking about the fellowship. This fellowship is accredited by Royal College of Surgeons of England. It's of 12 months. It's a paid fellowship. 3 posts per year. Starts from 1st of April every year. The applications for next year will close on this October end. Then there are 2-3 rounds of interviews, and just go on to our website voicelaser.com. You will find everything, or email us, phone us, and put in your application. We would like to welcome you all. Thank you.
I would also like to welcome Dr. Soumyajit Das sir and Dr. Utkal Mishra sir to chair this part of the segment.
Good afternoon, everyone. I am Lieutenant Colonel Anubhav Singh, and I am an ENT specialist currently posted at the Army Hospital in Tezpur, Assam. I'll be presenting my talk about artificial intelligence and machine learning in laryngology. I'll also be showing which you will need for developing your own AI and ML models. We will be going through the existing applications of AI and ML in laryngology, and then we'll be looking at some coding-free methods which we ourselves can use for developing our own very first machine learning model in laryngology. So the initial dreams of humans to build a machine which could recognize a problem, think on it, look for a solution, and then provide an intelligent solution to the problem, these were fraught with difficulties due to the limitations of early computing hardware. However, with passage of time, the computing power has tremendously increased. Train a computer to simulate human intelligence and the problem solving capabilities. So artificial intelligence refers to the ability of a machine or a computer system to simulate human intelligence, and that is how it is capable of performing tasks independently, and it can produce various outputs based on the inputs which it receives from the environment. Machine learning is a subset of artificial intelligence in which a system learns from the training data without being explicitly programmed to do the same. It does so by identification of patterns and trends within the database, based on which it can generate a machine learning model algorithm which can perform new tasks on the new data which it is given to. So how does AI and ML correlate with each other? Artificial intelligence is the broad system, and machine learning is a subset of the artificial intelligence. Within this machine learning, we have got various other things such as deep learning, convolutional neural networks, etc. Consider the ADAS system or the autopilot system in modern cars. How does it work? It has got two things which are integrated with each other. The machine learning system is the subset which is tasked with recognizing the various obstacles on the road, be it the cars, the pedestrians, and at the same time recognizing the traffic signals and sensing whether the signal is red or green. And based on this, it gives the outputs to the artificial intelligence system, which then controls whether the steering has to be moved left or right, and whether the accelerator or the brake pedal has to be controlled so that the car can move forward while navigating through the obstacles. So this is how artificial intelligence and machine learning are co-linked with each other. If you go through any article which describes about artificial intelligence and machine learning in otorhinolaryngology, you will come across a few terms which I will be showcasing to you. Firstly, we require a diverse data set. It is the data set on which our own machine learning models are going to be trained. And the quantity of the data determines the output which will be generated by the machine learning system. A larger database is going to lead to a higher accuracy. However, it comes at the cost of increased computing requirements, and more time will also be required for training the machine learning model. So therefore, we need a trade-off, and we need an optimally sized database so that we can balance against the computing power requirements as well as the training time. The database also has to be cleaned, it has to be processed to remove the outliers and also account for missing data so that our machine learning model can make correct predictions. There are various kinds of machine learning models: supervised, unsupervised, and reinforcement. In supervised machine learning algorithms, it is the training data set which contains the inputs as well as the desired outputs. And this is the most common type of machine learning models which are used in entire medicine. Unsupervised machine learning, in this, the training data does not contain the desired output. And in the reinforcement machine learning models, the output which is generated by the machine learning model is used as a feedback mechanism so that the machine learning model can improve upon itself. And also you will come across various terms which are related to the type of algorithms which various researchers are using to develop their own machine learning models. These range from very simple to very complex. The simplest ones can even be implemented within a web browser, whereas the complex ones will require a graphical processing unit and higher computing requirements. We need a system which has got a processor which needs to have a RAM, a GPU, and a storage devices. We will need software, our own machine learning system, which will run either on Linux or it can also run on Mac. We will need a programming language such as Python, and there are also relevant libraries which make machine learning possible. What are the existing applications of artificial intelligence in laryngology? These are related to voice analysis, video laryngoscopic images identification, and neck radiology. In voice analysis, the researchers have focused on differentiation of normal from the abnormal voice, identification of vocal pathologies based on voice. And in video laryngoscopic images, it has been used for the detection and identification of vocal pathologies. And in neck radiology, it is used to detect thyroid cartilage erosion as well as the identification of metastatic neck nodes in cases of malignancies. Voice has been said to be a signature of the laryngeal functions. Traditionally, we are aware that there are two kinds of voice analysis, the subjective and the objective methods. But however, none of them is available to the primary care physician. So a novel technique has been to use artificial intelligence and machine learning techniques so as to give the likely diagnosis based on the voice of the individual. How the system works is that the voice of the individual is taken, it is converted into a spectrogram. Now this spectrogram is a visual representation of an audiological data. The machine learning model is trained on this speech samples, and thereafter the machine learning model is able to classify the voice whether it is normal or laryngeal. Think of it as a future system wherein a patient phone calls to an ENT specialist so as to take an appointment. And while he is taking the appointment, the voice is being analyzed so that the ENT physician knows what is the likely pathology that the patient is suffering from even before the patient makes a visit. Now, to develop such a machine learning model on voice analysis, we require large samples or large quantities of data. However, some open source databases do exist which we can use for developing our machine learning models. However, we have a problem that most of these are collected by the Western world. The Saarbrücken is a German database, Massachusetts from the Americas. So we will have to ultimately resort to our own institutional voice databases if we want to localize it to the Indian population. Once the voice samples are collected, they will need to be analyzed, and thereafter these will be converted into MFCC so that the machine learning model can learn from this voice samples. And Based on the vocal samples, the normal voice as well as the voice which is generated through various lesions, these will be quite distinct from each other, based on which the computer is able to recognize and differentiate between the different kinds of voice which will be produced by individuals having different kinds of vocal lesions. So AI is being currently investigated for predicting vocal cord pathologies in primary care settings, and we have got some interesting results that differentiation from the normal to the abnormal voice, this can be done with 98% accuracy. However, the vocal cord pathologies can be predicted with 39 to 87% accuracy. However, if we compare the artificial intelligence to the general practitioners and the otolaryngologists, you will see that AI has got a much higher accuracy in predicting the vocal lesion just by listening to the voice alone, as compared to the ENT specialist and the general practitioners, whose accuracies are similar to each other, which has been found by a previous researcher. The figure shown on the right is a representation of the actual versus the predicted, and based on this, we see that the normal versus laryngeal diseases can be differentiated from each other with an accuracy of 0.85 to 0.97. Whereas if we go ahead and subclassify the diseases into benign, paralysis or malignancy, the accuracy slightly drops of the system. So we can say that the accuracy of the machine learning model is better than the laryngologists in predicting the vocal pathology, and also the time which is required for the analysis, the machine learning model can run through the entire data set within 30 seconds. So it can provide you a quick diagnosis just by listening to the voice alone. Whereas it has been seen that the human specialists will take about 40 to 80 minutes each by running through by listening and running through the entire database so as to predict what is the likely vocal pathology. And then too, their accuracy will be much less as compared to what the AI models can predict. The next is on video laryngoscopic images. AI has already been under development for predicting the vocal pathologies in live video laryngoscopies. Various researchers have developed various models which can differentiate between various categories of normal video laryngoscopic images versus benign lesions versus malignant lesions. The accuracies range in the range of 80 to 90%, and these are comparable to human experts with 20 years experience, which has been found by previous researchers. Identification of vocal fold pathologies depends on the instruments which will be required are a video laryngoscopy system or a stroboscope, from which images are acquired. Images or videos can be acquired. Videos can also be thereafter exported as still images, based on which a machine learning model can be trained, and then this machine learning model can be incorporated into the video laryngoscopy system itself, so that while the ENT specialist is performing the laryngoscopy, he can have an overlay of where the lesion is located and what is the likely lesion, whether it is a benign pathology or a malignant one, and what is the more likely subtype of the vocal pathology, which can be differentiated by the AI-based system. Various researchers have done studies on it. A previous researcher has tried to differentiate between vocal nodules, vocal malignancy and vocal polyp, and they have found that the identification of the vocal pathologies can be done quite accurately by the machine learning system. Another author has used a system which can differentiate carcinomas on the vocal cords versus benign lesions. And this is how the final machine learning model is able to differentiate and identify where the lesion is located on a live video, so that as an ENT specialist is performing the laryngoscopy, a second overlay can show where is the likely lesion and whether it is a carcinoma, so that targeted biopsies can be taken. Researchers have also implemented artificial intelligence based systems in radiology for two main things, which are for detection of metastatic nodes in head and neck carcinomas and for detecting whether the laryngeal cartilage is eroded or not in CT larynx images. They have found an accuracy with a sensitivity of 83% in picking up laryngeal erosions and a specificity of 64%. Differentiation of diseased larynx, that is larynx which is invaded by the carcinoma, versus a larynx which is intact, laryngeal cartilages which are intact, this can also be done and predicted by the machine learning based models. And also it has been increasingly been used for the detection of cervical lymph nodes, where the neck nodes are located and whether these are disease that is involved by the malignancy or not. this can also be differentiated by the machine learning models based on the subtle findings which differentiate a disease node versus a normal node. Now coming to the third part of the lecture, which is about making a basic artificial intelligence based model in laryngology for differentiation of laryngeal diseases. So there are a few coding free machine learning platforms which we can use. Out of them, the first three are very user friendly. Teachable Machine is a web based tool which can be implemented by any ENT specialist for development of ML models. CreateML is specific to Apple. RoboFlow is again a web based model, and the others shown below are free to try, but they require a subscription for actual implementation. Whenever we go for a machine learning model, we will need a database. And there are a few open source databases, repositories which are available online, which are free to use by any of the researchers, and we can use it to download our own machine learning databases, based on which we can train our machine learning model. So Teachable Machine is a web-based application. It is a very simple machine learning system which can be trained and tried by anyone. It does not require any knowledge of computing, and we don't need any specific hardware. All we need is a modern computer with a web browser, and based on which it can develop a machine learning model. So we go to Teachable Machine with .withgoogle.com. Once you go to this website, you will find that it asks you what kind of project you want to do. It can do classification on audio as well as images. So we choose images since we are going to do a laryngoscopic examination. Then we describe what are the categories. So we can name the categories as growths, benign lesion, no anatomical lesion, and leukoplakias. Once these categories are named, we will need to import the database. So in this case, I downloaded a database of images from the RoboFlow, which I then categorized and uploaded in the required categories on this website Teachable Machine. Once the model is uploaded, once the training data is uploaded, all we need to do is to click on train the model. For advanced applications, we can change the hyperparameters and see the results, how it affects the training. Once the training is done, for 250 epochs, we find that the machine learning model is trained. Thereafter, all we need to do is drag and drop new images on this window, and it will automatically categorize the new images which are being given to it. So if we give it an image over here, it is categorizing it as a benign lesion. Similarly, we tried, and it can categorize images into having no anatomical lesion, benign lesions versus growths which can be malignant versus leukoplakias. Similar thing can be done on an Apple Mac computer with the CreateML software. The advantage being that CreateML runs on local hardware, and it can do various advanced kinds of machine learning things, including image classification and object detection. It is a free to use software, and it does not require any payment or subscription costs. The machine learning model can be trained by loading the same database onto this software. The hyperparameters can be tuned. Once the machine learning model is trained, it is automatically giving us the accuracy figures which can be quoted later. And thereafter, we give it new images to predict, and it can provide us predictions along with the confidence regarding what is the likely lesion. Such as in this image, it is detecting a growth. Here it is detecting a growth. Here it is detecting leukoplakia, and here it is detecting a benign lesion. We have also ourselves tried an object detection model for the detection of laryngeal pathologies, and this was a part of the presentation which I gave today morning as part of my paper presentation. So a machine learning model can detect and track vocal lesions in video laryngoscopy on live videos. And this is the previous paper which we published regarding development of an AI-driven diagnostic model for detecting the paranasal sinuses on CT images, and thereafter classifying them whether the CT image shows sinus opacification or normal sinuses. What is the future of AI and ML in laryngology? It has got various healthcare applications. It can be used as a screening tool for laryngeal diagnostics. It can augment the clinicians in interpreting the clinical as well as the radiological images. It can be used for training of the students and paramedics, and it can be incorporated into the diagnostic modalities at the level of primary and secondary level healthcare facilities. It can also provide boost to the telemedicine, wherein a MO who is sitting in a peripheral healthcare center, if he can obtain an image of the larynx, he can transmit it through the video, and then AI can give a most likely diagnosis based on which the patient can be decided when to refer and where to refer. And also it has got various research applications. However, the system has got various limitations. For the physicians might be compelled to follow the suggestion of the AI and fall to a confirmation bias. For the patients, it can result in loss of autonomy, and also it has got various other ethical and legal issues regarding who is actually responsible in case an AI misdiagnoses a condition. Is the programmer who is going to be responsible, or is it the end user who is going to be responsible? Also, there is a black box phenomena wherein in many machine learning technologies, it cannot be directly explained how the system is working in order to give the classification as to what is the most likely lesion. Also, it has been seen that many of the machine learning models have got worse performance than expected when they are put to real world use. This is going to happen in case the training database does not conform to the local population. However, AI still holds considerable future in healthcare, and the various big technological companies including Apple, Google as well as Microsoft are betting big on such technologies. These are the references. Thank you. If there are any questions, I can answer. Thank you. Sir, for training a machine learning model, you will require a minimum of 1000 images per category. So if you are trying to differentiate between benign versus malignant, 1000 images of each and every category will do. However, if you are going to do a sub-classification of benign pathologies such as vocal cord polyps, nodules, papillomas, granulomas, in that case each and every subcategory will also require at least 1000 images to have significant accuracy. Sir. Thank you, sir.
Thank you very much, sir. We deeply appreciate your insightful talk on the topic of AI in laryngology. Now, continuing with the session, I would like to call upon the stage Dr. Rakesh Datta, sir, for his topic on imagining the future of laryngology.
Good afternoon to the people who are still standing strong. The future of laryngology is being discussed at a time when not many people are around, but does not matter. I still shall bash on regardless. I will just wait for the future of my laptop to be corrected before we talk about laryngology. So, we have been here for the last 3 days and had a very engaging discussion. We have talked about a lot of surgical techniques, diagnostic techniques. We're talking about how laryngology should be practiced. But what's equally important is that we are addressing a set of people who are not going to practice the way it exists. The future is changing very rapidly. The future is going to have a lot of surprises, and the future is going to really be a challenge to a large number of us. So let me just be a bit of a wild guess of how we can go ahead and what may happen in laryngology as we move ahead. So is that corrected now?
I'm not sure whether it's allowed or not, but he's been on the central government committees to decide the healthcare and the AI and new technology for the institutes and future, what is it, plan. I mean, it's all that's secret, but I know of this some discussion. So I think he holds quite a bit of views in designing and running the educational programs and looking into the basically planning the future things.
Thank you, sir. Just give it a So we'll start from where we were discussing and leave. But we are talking about imagining the future. So the key word here is imagining. Okay, it might be an imagination. Please don't take it very, very seriously at times. Don't think that he hoga. As any other crystal ball gazer who, even a clock is correct twice a day. Even the hands of a clock are correct twice a day. So it's just imagination, and let's see if we can base it on a bit more thing. So a disclaimer, there is no conflict of interest. I am not funded for this. The views expressed are very personal. And why do I talk on these type of topics is, in fact, I was mentioning yesterday in the party that it's been probably 3 years that I've been really practicing active ENT. I have been into a lot of other fields as well, and as what Dr. Gandhi said, that into a bit of policy making as well, where I'm looking at the last line, the current job includes something called as perspective planning. So it is something like Niti Aayog equivalent for the Armed Forces Medical Services, where we make policies, and I'm also driving digital health in this context. Over a period of time, I managed to acquire a varied set of qualifications, which made me think that healthcare is much more beyond simply seeing a patient, evaluating a patient. It starts like that for everyone, I guess. There's a path. And eventually you realize that to make an impact at a larger scale, a community approach definitely should be kept in mind. The next thing which is very important to understand is this statement by Bill Gates. And what he says is very true. And when I read about this, I myself realized, how true this is. We tend to overestimate what will happen in 2 years. We'll say, 2 saal mein sab badal jayega. But when it comes to 10 years perspective, we underestimate. Now look back 10 years. You realize that the practice was so different. 10 years is a huge time to change technology, but we are underestimated. But we think 2 saal mein sab badal jayega. So it doesn't happen that way. So remember, we are looking at long term. Many of you would be teachers, many of you would be professors in medical colleges, and would remember this pencil drawing which we used to do routinely in our OPD slips. Many of us still may believe very strongly in it. I'll be very honest and candid and say, probably I have not done an ideal for a while now, years that is, and yes, we may still insist for a resident, nahi, tumhe ideal karna nahi aata and all that, light nahi hoga to kya karoge. But let me be very honest, when was the last time I did it? It's been a while, and making this diagram and sort of putting these labels has also been a while. So the message is not that, the message is that things have changed rapidly already. So I have a question for you, and Dr. Sachin, I know, is planning a huge voice clinic in Pune. So let me pose a question. What will be the voice clinic of 2045 look like? 20 more years from hence. What do you think voice clinic will look like? Any guesses? No one knows, but it might be very different. So that's the thing which you should start thinking, that you are preparing for when you're finished, you're an ISR, you're trying to do, you're going to practice in the future. So the voice clinic of the future is very different. The way technology is changing healthcare big time, we have to realize this as we move ahead. I will give you one scenario, okay? Now this is a wild scenario. The whole talk is about imagination. But read a bit carefully, word by word, or let's say line by line and twice. So imagine this scenario, that there's a singer who's in a rural area and she has hoarseness. Her earbuds tell something is wrong. Why? Because they are always listening to you. They are smart. They detect there is some alteration in the voice. They send an alert. Hey, something is wrong. Please go have it yourself checked. She records she has a smart ring. She records her voice, which goes onto a cloud. And an AI system says something is wrong. Already you saw that the percentage of accuracy is 85% plus already. We may not have the lesion in hand, but we know something is wrong. The AI has already told her that something is wrong. She schedules a virtual consult. It's done by the AI. The scheduling is also doesn't require a person. And she is sent an endoscope by a courier, maybe a Blinkit equivalent, which is like a thread, which you don't have to really administer or put in. You just have to sort of swallow it and leave it for a while there, and it just feels like a bit of a thing and biodegrades. It's like a chewing gum maybe. And what happens? And how does she do it? Using augmented reality. So she's even taught how to do this particular thing. And what happens? The live feed is uploaded. It is analyzed on a medical cloud. And within minutes, based on a digital twin technology. Now, digital twin technology is that everyone's DNA is kept, matched. All your life is being recorded digitally in a different server. And it is making predictions on your behalf. So whatever has to be tested, it's already being done, by the way. Digital twins, many of you might be aware that if I want to do a particular cardiac intervention and I'm looking at a digital twin, so what I can do actually is to look at, do that procedure virtually to find my outcomes, chances of success. So now superimpose it in your genetic data, your risk factors, your habits, which the smart systems already knows. And what happens? You have generated a risk. So with all of this, it comes to a laryngologist. Okay, so laryngologist sees it with the risk profile, with the percentage, with the lesion which is marked by AI, and which may or may not be right. So there is a validation process. There is a human in this entire loop. The further we go, the treatment planning, the follow-up, as well as the consultation takes place using a virtual mode. How many of you have seen a virtual assistant in practice? Last year we had a session in Mysore, and I remember playing the video where NVIDIA gives you virtual assistants by the hour. So what they are essentially beings which are virtual, and you converse with them like generative AI, something like ChatGPT, but they are video, and they are trained to counsel you on a particular skill. So this particular skill might be speech-language pathology. It might be pre-operative counseling of tracheostomy. So they are trained thoroughly. And the person asks them a question and gets an answer. And there's a video which you're talking to. That person doesn't exist actually. It's all a virtual agent, they call it. So an agent talks to you and counsels you probably better and legally more correctly and without any conflicts or biases, hopefully. And what happens? All this time, your regular feedback is being provided virtually to a cloud, and you are being monitored. So you can just imagine these things. So a virtual clinic of 2025 might be something like this sort. The scope is much beyond surgery. We've been discussing, if you see a percentage analysis, I was discussing again yesterday, I think with Panju, that if you see the programs at which we do, we look and spend a lot of time on many surgery. This is what I've done, this is my technique, this is my thing. But you see, healthcare is much, much more beyond surgery. In fact, it should start from a preventive aspect, a promotive aspect. And how we go and how we handle this reflects how laryngology will move. So we have to look at technology is going to intervene not only in your surgery or therapeutics, but also in diagnostics, as well as preventive and promotive aspects of At the implementation level, technology or the future can be divided into two broad aspects. One is where AI or other technology is going to assist and augment. And the other plane is when it's going to replace. Dr. Gandhi yesterday was saying that sooner or later, maybe 10 years later was your thought, that probably some of us are getting replaced. It's the fact, we're getting replaced. So to some extent, we need to look at this particular angle when we are discussing forward. To look into the future. Actually, you think this is something very strong, or do you accept what I'm saying? You think it's going to happen? I don't know, no one knows. But to look into the future, let's look into the past. And I have two slides to give an argument of why this might be the case. And I will give you examples in the column number 2 of certain technological, we call them technology of that time, of that particular period, which has surpassed human capability. Column number 2 is not human capability. humans were not having fire with them, but they mastered fire. At that time, it must be felt that we are playing with fire, we'll get burnt. Look at each of these technologies which have come in. Gunpowder, it gave the human ability to kill a person at a distance of 100 meters maybe. Is it a human ability? It is not a human ability. It is something which we have sort of taken over and now mastered that technology. For good or bad is a different issue. But what is very important to understand is this is not the first change that we need to worry that we have humans are going to get wiped off and humanity is going to go and they are going to take us over. Similarly, electricity. When electricity came, the thought was the electricity is going to kill everyone. Electricity was something based on which movies have been made. Frankenstein was made. Bijli lagi, monster ban gaya. Remember? Electricity was feared so much that paintings were there in London about people hanging from the electric wires. Animals hanging, and they have all died. That was the sort of phobia which electricity created. This is not all. The second slide has more. And you imagine each of these technologies. Let's take at aeroplanes for that matter, flying, the ability to fly and traverse distances. So each of this technology is something which has changed and surpassed human capability. None of this was intrinsic to us as biological. A genetic code never meant us to do anything of this. We have used telegraph to bridge distances across miles. The fact that we are sitting here and having this conference and we have a camera shooting at us, which is being broadcast live on a YouTube, is what? It's not a human ability at all. It is superhuman. So it is something which we have always been doing. What's important is to also look at the future in such a way and master it, be part of it, and ride the change in a way that we adopt it faster before we get redundant. So that is what is more important. What is common in all these technologies is the fact that they are disruptive. They are disruptive because they are changing the way existing people who do not adopt it get left out. So there was a very interesting cartoon which someone had forwarded to me on WhatsApp. I could not put it here. I couldn't get it on the net incidentally. It was about a stone man sitting next to a bundle of hay, and two other stone men are coming and doing farming. And this guy is sitting with a begging bowl. And he says, this revolution has taken my job away because he was what? He was a hunter. So he is now feeling that ab to mera sab khatam ho gaya, main barbaad ho gaya, and he's sitting with a begging bowl. And the other new people are now doing farming. So even imagine such a small change in society has changed the way people work. So ladies and gentlemen, meet your new co-worker, which is technology. And your future actually is going to be based on technology-enabled practice. I will now go through 5 slides, and that's the crux of the talk, of how the emerging technology on the horizon is likely to affect laryngology. They're likely to, it's imagination, okay? So one huge technology which has already been discussed a bit by Dr. Anubhav is AI and machine learning. When we are talking about AI and machine learning, we are looking at multiple use cases. This includes from a predictive voice diagnostics, which is using acoustics only. Just by hearing your voice, can I make a diagnosis? A real-time analysis of laryngeal movement and lessons from and lesions from videoscopy. A virtual pathologist for live margins. We are already seeing yesterday in the videos, we were seeing scopes which are touching and trying to do feedback, and then we are trying to say whether it's benign or malignant for margins. Add AI to it. And an AI enforced surgical precision and bounds. Why so enforced? Because as we said, there are certain places for safety where AI can put in algorithms where you're forced to do a particular thing and not really be advised. So AI does control us as well. It may be in cases of patient safety. The other emerging technology on the horizon which is going to affect healthcare overall is regenerative medicine. Now we have to look at how regenerative medicine can be adopted. We have some very unique problems. One of the most unique problems actually, if you see with human beings and many diseases, is what? Is fibrosis. We have not mastered fibrosis. We can inject some steroid, we can do some this thing, but we have not been able to. And many times what we are doing is actually treating what? Scarring. What is scarring? Scarring is the effect of an injury. So one of the particular thing which can probably be very, very important when it comes to the upper airway is can we address this? And I think in the future, regenerative medicine has the answer. We already are talking about today in the quiz, it was a question how many rings if they're lost, after which beyond we can't do anything. So can we have a new trachea? Can we bioprint a new trachea? It's been tried out in animals, you may have read about it. Can we bioprint a particular type of tissue? Can we, the lamina propria, if it goes away, it doesn't regenerate very well. So we have been injecting things which with a lot of fibroblasts and all also in trials, but really not trying to get. There is no tissue in the body which we have been able to find where if you see the vocal cord for a moment, it is vibrating like a blanket over a sheet of water and a muscle 256 times per second without phonotrauma. It's a huge biomechanical feat. As I speak in this lecture, I may have, perhaps my vocal cord would have vibrated what, a couple of lakhs or maybe more times without a phonotrauma. So this type of ability, no human being has been able to replicate by injecting things or putting blasts or whatever. But regenerative medicine, to try to regenerate that type of tissue probably might hold the answer. The next emerging tech which is affecting healthcare largely is minimally invasive. I imagined a thread. It might be tinier, it might be larger. You might be having micro robotics. Flexible robotics definitely we already have, but the flexibility and dexterity and the degrees of motion might be more. You may have remote optics and you may have a physiological assessment. If you realize every time we have managed to see the larynx, we have discovered more about it. We did not know how we spoke till the time someone saw the larynx in a mirror. Then we realized there is something known as a voice box which was only seen post death of a person. We started seeing it live. Then we realized something vibrates. Then someone discovered that there is a mucosal wave also. Still when we are evaluating and seeing human voice as a function, we are doing something unphysiological by pulling out the tongue or putting something inside. We have not been able to fully assess speech as physiology because it's very difficult to see it as it happens. So maybe some advanced optics do it or some other tools come in. The next thing which is big is coming is wearable tech. And wearable tech does not mean having it on your wrist necessarily, it may be also embedded. So the voice can be used to, you have to start thinking, can be used to make diagnosis or used to make inferences beyond laryngology also. Can the voice be used to find out if a person is depressed? Can it be used? Maybe if someone gives a call in and the algorithm says this guy is, something is wrong, he is suicidal. Maybe. I'm not trying to give you a ready-made answer, but what I'm trying to say that voice can be used to make other diagnoses as well. Early detection and warning. Can we have an e-tattoo? An e-tattoo is a small thing which is sort of stuck to the particular place, which also has got embedded circuitry. Can it continuously monitor and give us better patterns? Variable neural devices to augment voice. Can I say that I want to tune my voice? I want to go up my pitch by 5 decibels, by say 20 hertz. Can I use that using a pacing technique? We all know about brain-computer interface. We already know that there are situations where you think something and something moves. You must have all read about it. Can there be a brain-voice interface? We already have a similar thing when Anubhav was telling me about Stephen Hawking. He writes something on the pad and it is spoken. But can that be bridged also better? When he thinks something, he speaks that. Can we have solutions which can provide answers to problems which we don't have yet? The next thing which is there is AR and VR. Now I'm talking of various large technology heads and how they can apply to laryngology. Immersive consultations we already mentioned. In the small scenario which we talked about, we already have, we already used that example of how a virtual consult can take place. The therapy is fully going online already. Can we do remote diagnostics? And instead of saying the doctor will see you now, probably the agent will see you now before the doctor sees you. The next thing is precision medicine, which is again a trend which is across healthcare. I'm not singling out laryngology, but everything will have an effect on laryngology. So genomic profiling, what is the risk of a particular disease happening to you? real-time pooled risk profiling, which basically means it's not only taking genetics, it's again the same digital twin thing which we mentioned in our example. A digital twin which is now predicting that it is likely that this person is going to have this trauma as and when this person is singing. Similarly, we need to look at personalized treatment algorithms. They are already happening in oncology, and I'm sure they will happen elsewhere also. The treatment will be tailor-made. So is it all that rosy? Well, I don't think so, but then there's no harm in, there will be biases, there will be challenges which were mentioned in the previous talk as well. There will be problems, there will be garbage in, garbage out. Data, if data is not good, data will be not, the output will not be good. But that happens in research even today. Even in research, poorly followed research, if it's garbage, you still get a finding. So let's not blame the technology for it. That's us who's feeding the data. And we need to make sure that we regulate it well, otherwise it will start regulating us. So that is very important. So what finally, I think a call to action would be, let us be the pioneers of this new chapter. We are not going to avoid it in any case. The young people who are sitting and who are just come back from the quiz, please remember, we are not going to avoid it. You are going to face it. And to face it, the best thing is to ride on it. And riding on it is that means you must master it. There were, if you noticed, a few studies which were shown by Dr. Anubhav in the previous presentation. A large number of studies which are there on AI are being done by non-medical people, by engineers. They are making algorithms and deciding what you have. And we very gladly collaborate with them and say, okay, here's the data, please tell us how to do it. Please understand, this is something where you are using your intellect to make a product which is actually working against you in one way or the other. I'm not against it, but what is important is to master it. Do not get into this trap of getting and sharing data with your engineering colleagues just because they can make a model. You can make a model. You will interpret it, design it, and customize it to your patient far better, because that engineer still, after taking all that data and making all that models, we never be accountable for it. Who's accountable? The doctor is accountable. So if you are accountable, why don't you make your model? Why don't you make your solutions? And why don't you adopt? Otherwise, what you're doing is putting all your eggs in someone else's basket. He's making something which you trust and be answerable. So I think to some extent, we have to be stakeholders in this entire process far more than simply being the data providers and users. We also have to understand this technology. So that is something which my message is. If there are any question, comments, or for the AI people, any prompts, I'll be happy to answer right now. And we look forward to meeting you otherwise also on multiple platforms. Thank you. Any questions?
As you have rightly pointed out, there was recently news in the newspaper that by ear wax one can get the status of the diabetes in the patient, and it is giving more precise than HbA1c.
So look.
So HbA1c is now defeated by wax in the ear. They have analyzed the data from the wax, and they can predict diabetes in a person.
Wonderful. I never knew about this, but then that's interesting.
There was a news.
Yeah, must be. So what's also important to understand as we are saying this, see, many times there are two other terms which I must bring in here for the youngsters especially, something known as explainable AI. You would have read about this. AI is something which is corroborating what is happening and what are the cofactors. Okay, it might be that it might be as wild and as stupid that if I wear a red shirt, I am likely to have diabetes more, which makes no sense. So there is a concept of explainable AI, and that's where the humans come in, that's where doctors come in, where they try to make sense out of this thing and say, okay, this is garbage, let's check it out. But mind you, many times what seems garbage might not be garbage. Did we till even few years back know how radiation therapy works? We used it. We knew it melted tumors. Did we know how it worked? Did we know what happened at a cellular level? How did the damage take place? We didn't even understand. But we used it because we had evidence and corroboration. So like many of the models which are a black box, we yet do not understand what's happening inside. Probably if they are working fine, it is better to use them because it's going to benefit your patient. But yes, one day maybe you get the logic of how it's working. AI to a large extent still is a black box. We do not know what's happening inside. What is the one model which is coming? A lot of your assistants are going to go away. A lot of your counseling is going to be taken over. Our job, which AI yet cannot really replace, is the humane touch, the confidence building, and giving the patient the assurance that he is in safe hands. This is something which we probably as doctors need to look at in a much more distinct from our training of MBBS days onwards.
There's one more fact.
Yeah.
Our audible sensitivity is up to 20 Hz to 20,000 Hz.
Yes.
Similar for visual acuity also. So again there is something कि जीवन में बहुत सारे अनसुनी अनदेखी रह जाएंगी, which will be held by the machines. There are number of speeches and sounds. We are limited to 20,000 Hz only.
Absolutely. We are limited by our senses.
So there
We
are
are
many
limited
things
by our
that
sensory system.
we have to accept it.
Yes. Exactly.
Talk regarding this spacing. I was in, you know, KPIT. KPIT is a multinational company actually. It's doing the automobile this one softwares, third largest in the world. So I just told him, can we make these spacers for abductor palsy and everything? He said, Sir, Sachin, yes, why not? But Sachin, I will make a chip. You just put in your vocal cords and we made some controls. Lata Mangeshkar, press this. The vocal cord would vibrate. See, he's thinking. Asha Bose, just another button. He will start singing Asha Bose. But I think it may come true.
So our question of how will be the voice clinic of Greenath Mangeshkar in the new location after 20 years remains to be seen, but I'm sure it will be a lot different and it will be for the good only. Thank you very much.
वैक्स तो होता है
नहीं होता कभी कभी
तो उसका तो ब्लड तो लेंगे ही ना
बिल्कुल नहीं होता है
Thank you very much, sir, for such a thought-provoking talk that shed light on future possibilities in the field of laryngology. Now for the next talk, I would like to call upon stage Dr. Bharat sir for his topic autologous rib graft and temporoparietal facial free flap.
मैम वैक्स इज नॉन इन्वेसिव प्रोसीजर नहीं तो ब्लड तो लेंगे ही नहीं वी आर लुकिंग फॉर नॉन इन्वेसिव we have to accept the changes. There is no option. Those who don't, they are left behind.
Hi all. I just wanted to say one more time how incredible it's been to hear from everybody this weekend. It's been really thought-provoking for me and informative to see how you treat laryngeal conditions, some of which I just never see. And it's been great. Thank you so much for having me and Dr. Jayarajan. It's been great. And again, thanks Dr. Gandhi for having us out here. I'm going to make this really nice and short and sweet. This is like 5 or 6 slides, so I want to get you guys out of here as soon as possible. This is a technique that, again, Dr. Jayarajan and I came up together when I first got to UAB. We were looking for creative ways to reconstruct open partial laryngectomy defects. And you know, I am certain that open partial laryngectomies are more common here than they are in the States. It's a surgical art that's really fallen by the wayside, but it's one that certainly has value in situations where patients are not eligible for definitive chemoradiotherapy for stage 3 laryngeal cancers. I think a big part of the reason why things have fallen by the wayside is just a change in philosophy about when to consider non-surgical techniques, and the less people do it, the less likely it is that their trainees learn to do it and think about it. But Harry and I did about 5 vertical partial laryngectomies, had pretty good outcomes, and I just want to share with you what we came up with in terms of the reconstructive technique. You know, historically, when people have thought about how to reconstruct partial laryngectomy defects, there's a lot of interesting work that's currently ongoing. David Lott in Arizona developing a substrate for basically insinuation of a neolarynx. But outside of that, if you think about historically, when partial laryngectomies are done, patients are left with pretty prohibitive valvular insufficiency. And if we're going to start implementing this as a potential treatment option, we wanted to think about a way to make people's function a little bit better. Status quo, I think most of us that do this kind of surgery are familiar with the history. There are a number of things that have been published in the literature, and when there's a number of things published in the literature, it usually means that there isn't a single best option. Historically, there's been advocacy for cartilage prefabrication in order to maximize the probability of cartilage persistence when considering reconstructive options for the larynx and the trachea. And this is a technique we developed for both laryngeal and tracheal reconstruction. I'll show a case of each of them. So basically, the purpose of this talk is to describe this novel technique of what we called a sandwich temporoparietal fascia free flap with an autologous rib graft that's done all in a single stage without any prefabrication. The novelty here being that the temporoparietal fascia free flap is a free flap, so it's vascularized. And to provide a layer for neomucosalization, the sandwich aspect of it is basically based on insinuating the graft between the temporalis and the temporoparietal fascia, which you'll see here soon. So the first case, 24-year-old gentleman who had had a prior cricotracheal resection reconstruction years prior to seeing Dr. Jayarajan in clinic. And I'll show you the video of how significant this stenosis was. He had an anterior and posterior cricoid expansion. Unfortunately, after doing okay in the beginning, after the cartilage degraded as it's wont to do, was left with, again, pretty significant laryngotracheal stenosis. We wanted to help him, 24-year-old, really, really nice kid. And by this time, we'd actually done this flap reconstruction, it's going out of order a little bit, for 3 or 4 of our vertical partial laryngectomy patients. And we figured this might be a good option for him to insinuate into the trachea instead of the larynx. Basic procedure, unfortunately, I don't have a video of what we did in the operating room. We weren't thinking that far ahead, so I apologize. So some of this you're just going to have to imagine. But we skeletonized larynx and trachea, of course, perform a vertical cricotracheotomy to distract the edges and create an opening for the insinuation of the flap. He actually had fairly significant subglottic stenosis as well, so the decision we made was to do an open Mattern procedure with a stent and a microturbidal resection out to the perichondrium, and then do an expansion free flap reconstruction of the tracheal segment. I harvest rib, I shape it with a 2-0 diamond into an oval. Dr. Jayarajan takes the temporoparietal fascia free flap and develops this pocket between the temporoparietal fascia and the temporalis fascia in order to accommodate the graft. And then we parachute it into the vertical tracheotomy. So let me show you what he looks like here. This is him in the operating room pre-op. And this is a little bit more dramatic than what is actually reality. His airway collapses a little bit when he goes up into suspension. It's not quite that bad, but it's pretty bad. But as you can see, the proximal segment, we have that subglottic stenosis as well. This is what he looked like preoperatively. You can see that rib reconstruction there from his initial surgery. That's what it looks like post-op. So basically what you're seeing is the temporoparietal fascia free flap that's draped over the reconstructed trachea. There's a stent in place, but inside, and you can't see it, the rib is situated between those 2 layers and between the vertical tracheotomy that we made. This is what he looked like at his first post-operative visit. I believe this was 2 weeks after. Actually quite remarkable, and we have now a 1.5 years of follow-up. And a small portion of the rib is visible, but for the most part, he's remucosalized and he's doing fantastic. He ran a mile for the first time in about 13 years, and it was a really nice story. This is his 10-month post-op CT scan. You know, the incremental advantage, as we saw it in insinuating the rib into the temporoparietal fascia free flap, was hopefully to cause some inosculation and keep the rib alive. And as you can see, that rib is very much still present. And that's 10 months post-op and is still forcing that anterior expansion, so it worked exactly the way that we wanted. So this was a decided success. We also use this for some of our vertical partial laryngectomy defects. The procedure is a little bit different, so instead of just putting an oval shape to be accommodated into a vertical tracheotomy, instead what I do after I harvest the rib is I drill out a little facet here that's pushed into a residual 2 to 3 millimeter posterior thyroid cartilage strut after the vertical partial laryngectomy is done, which you can see here. You can sort of see that facet onto the strut, and that's draped over the resected portion of the larynx and then plated to the contralateral larynx. When I shape this, I shape it so that the endoluminal edge is a little bit rounded, again to emulate the basic superstructure of a vocal fold, again to hopefully get some valvular competency. And then this is draped with the temporoparietal fascia free flap that's sutured to the cricothyroid membrane inferiorly in order to reconstruct the entirety of the hemilaryngeal defect. This is what they look like post-op. So this is the anterograde view. Again, I'm sorry I don't have a video, unfortunately. This is the retrograde view. So you can see that the hemilaryngeal defect is fully reconstructed with complete valvular competency. Worked pretty well. We had one patient that had significant cicatricial fibrosis, and it turns out he actually had recurrence some months later. That was after I actually put this table together. But everybody else was decannulated within max of 5 months. Everybody went home on a regular diet. Again, not perfect, as with every other partial laryngectomy reconstruction, but is something that, again, we thought would be valuable sharing as something to harbor in your armamentarium in reconstructing this challenging laryngeal and tracheal defect. Benefits, single stage, rib persists, and we saw that with both the laryngeal and the tracheal reconstruction. There was only partial resorption at the 10-month follow-up, and he's still doing fantastic. One of the cases had pretty significant cicatricial fibrosis that I still don't fully understand, but the rest were decannulated. So anyhow, thank you guys.
Thank you so much, sir, for such a wonderful presentation. Now, as we conclude this session, we would like to extend gratitude to our esteemed speakers and chairpersons for their valuable contribution. I would now like to call upon Dr. Manjunath, sir, to extend a token of appreciation to Dr. Soumyajit Das. Dr. Rajbala Baduria, ma'am, to felicitate Dr. Rakesh Datta, sir. And I would request Dr. Sachin Gandhi, sir, to felicitate Dr. Utkal Mishra, sir.
प्लस ये कुछ समझा नहीं। रुक 1 मिनट रुक जा, मैं लगा रहा हूँ, तो शूट कर रहा हूँ, 1 मिनट लगा।
some stressful times also. So if I said something which you didn't like, I am extremely sorry for that to all of you. But this is how we have to bring everything together. Sometimes we have to do that. I'm really sorry if I hurt the sentiments of anyone. And this is for my team also, because we had a lot of stressful times, so I might not have sounded the way I usually sound, but this is, and thanks everyone that it has ended very, very well, and we have been able to execute it very well. So as we are ending towards, so I would like all the senior people to come on the stage. Everyone can be please here, and we'll be announcing the results of the various categories of the competitions which we had here. Dr. Ajwala Bhadoria, Madam, Dr. Aparna, Dr. Smita Soni, sir, Dr. Manjuna, Dr. Sachin Gandhi, sir, please come on the stage. All can. That would be a better way to do. So, sir, okay. Dr. Jan, Adi. So the first paper presentation category was the Senior Consultant Award, and we had a tough time over there. So congratulations to both the first prize winners. So it's a tie between Professor Kavita Sachdev Madam and Dr. Yamini, Professor Yamini. So Kavita Madam is, I think, she is not here. So anybody from Jabalpur is here, may I please come and. So there is a. So it's a certificate for the first prize, and then there is a cash prize award of. There's a cash prize award. So anybody from Jabalpur team, like otherwise will send it to her. So the next category was Junior Consultant Award paper. The first is, the winner is Dr. Nabab Singh from Tezpur. In all the categories, there are cash awards which are there. The second is Dr. Shashank Gupta. ये तो पता नहीं। हाँ। The third in this category is Dr. Pratha Rai. Dr. Pratha Rai. So these are the Dr. B.M. ABROL, late Dr. B.M. ABROL awards, after whose name these awards have been named by the LVA. The third in this category is PG Award paper. The first prize goes to Dr. Sonal Jangra. The second prize goes to Dr. Soumya Maskara. Soumya. The third prize goes to Dr. Kathat Basani. Now we come to the e-poster awards, the poster presentations. The first one goes to Dr. Shivani Dikshit. Dr. Neha Agrawal. The second prize goes to Dr. Neha Agrawal. And the third prize in this category goes to Dr. Rakhi Raghavan. So the next event, which was the next big academic event, was the quiz, which was very, very well organized by Dr. Prasoon Mishra and Dr. Venkatesh VK, and we all enjoyed it very much. In the meantime, when people were here in the panel discussion, sorry sir, we were enjoying there. So this quiz is actually in the name of late Professor Dr. Arun Goel, and he was the man for the bronchoscopy. Whatever bronchoscopy I learned, I did also work quite some time in UCMS, and I had the opportunity to be trained under him. And he was ultimate person in the bronchoscopy, the calmness, the meticulous planning for all the foreign bodies he would do. So I didn't see him ever being fail in the foreign body removal, whatever the foreign body, how old is the foreign body. So this, unfortunately, we lost him, I think around a year back, because of some disease. So this quiz is in the name of Professor Dr. Arun Goel. So the first prize goes to
the third prize goes to Dr. Soumya Maskara and Dr. Kathat Basani.
the second. This team is from MGM.
Third prize is Dr. Soumya
Maskara. Dr. Soumya Maskara and Dr. Kirtar. There's a gas pipe.
There's a trophy and certificate both, and cash prize also. Any guesses for second prize? Anyone volunteering for second prize? Second prize goes to Dr. Trisha Chatterjee and Dr. Pooja. Till then, any guesses for first prize now? There were more than 3 teams, no? Oh, sorry. The first prize goes to Dr. Devgroup and Dr. Fasil. Again from AIMS Bhopal.
I just want to, Dr. Arun Goel, I mean,
he was having that pathology for maybe more than 15 years. And till his almost a week ahead, he was with us in the conferences. And so soft-spoken, happy person, we were never able to think over he has got such a pathology which is going to get him out of all of us. And he was a wonderful person, and I have learned a lot of things from him for laryngeal exposure actually, and fantastic person. Thank you.
We must also thank the quiz masters, especially Dr. Venkatesh, for a very innovatively done quiz. And he did a fantastic job with the online live session as well. Wonderful.
Dr. Soumya Maskara now she is there. She may please come forward for second prize in PGP award paper presentation.
Any other winners have reached in the hall, please come. I think Dr. Pritha Roy is also there, ना? उसके नाम भी कोई प्राइज थे. She is also there. जिसने प्राइज जीता है बाहर न्यूज़ मिल गई आ जाएं.
PG award paper third prize goes to Dr. Kirtar Basani. Dr. Kirtar. Wow.
Before we end up,
Dr. Junior Consultant Award paper, third prize, Dr. Pritha Roy. Dr. Rakhi Raghavan for third prize in poster presentation.
Last prize is करोड़पति बन गया.
A big applause for Dr. Vikas Gupta. Please come, all of you please come forward for a group photograph. Whosoever is there. सारे आ जाओ. अरे जल्दी कर ले।
कीर्ति और मैडम आप यामिनी मैडम आई
अरे आओ।
यामिनी मैडम आई
अरे आ जाओ सबको बोला।
लाइट कम है ना, लाइट देनी होगी।
उनको फोन दे दो ना। हाँ, अरे लेके नहीं जाएंगे आप। One, two.
Ready? Smile.
Yes.
Thank you.
So with lunch, so let's all have lunch together. But before we discuss, I have a bad habit of not taking the names, but I am correcting myself. So if I should be failing because I have taken the names of all the LVA executives, but I must take the names of Gankalyan, Rahul, Dhanush, Shubham. So whatever you are seeing here is actually because of them. As usual, we always say that ये करना है, वो करना है, but करना कैसे है? They have told me that how to do it. And if we have gone home at 11 o'clock, it was at least Rahul and Gankalyan who were always there. If I'm leaving at 11:30, 12, whatever, I think few days we left at 12 o'clock, but they were always there. They were the last persons to stand with me all the time. And all the residents, obviously they were also looking for the wards and all. In the meantime, we all were very busy with all these things. So thank you very much, all of you.